Good evening to everyone. I hope all of you are settled down. We'll start in about a minute now. So I would request Dr. Dhananjay Bapat, President, Pet Practitioners Association of Mumbai, to start the proceedings of the day with a welcome note.
Hi to everyone. Thanks for all PPM members and all our veterinary faculty to be here. I would like to thank Karthik sir to inviting us and having this great event here. And we will go ahead. Thank you, sir.
Thank you so much, Dr. Bapat. And welcome to all of you for the Dermatology Summit 2023. At the outset, I would like to introduce the speakers to you for the evening today, starting with Dr. Rosanna Marcella. Dr. Rosanna is from Florida, United States of America. She is a professor of small animal clinical sciences at the College of Veterinary Medicine, University of Florida. Dr. Marcella is a diplomate of the American College of Veterinary Dermatology and a full professor at the University of Florida. She has served as the co-editor of Veterinary Dermatology and is a member of the task force on canine atopic dermatitis. She also has co-edited the current British Sava Dermatology Manual. Dr. Marcella is a graduate of the University of Milan, where she passed out in 1991. After passing out, she did her private practice and then moved to the US, where she specialized in dermatology. And after getting board certified in 1996, she joined the University of Florida as professor there. Dr. Marcella has authored more than 150 peer-reviewed publications in various journals, and she has also written a lot of books, among which are the Manual of Equine Dermatology and Clinical Approach to Feline Dermatological Diseases. And she has also contributed to many other publications, both as author as well as editor, an example of which is the British Sava Manual of Feline Dermatology and Canine Dermatology. She has also served in the past as the president of the American College of Veterinary Dermatology, what we know as ACVD, and she has been a co-editor of the Veterinary Dermatology Journal as well. She is a horse lover, and she has a special interest in equine dermatology. And she has published quite a lot of papers on equine allergies, their diagnosis and treatment. So I would request Dr. Bapat to welcome Dr. Marcella with a bouquet. Thank you so much, sir. Thank you so much, ma'am. The second speaker for the day, I'm sure all of us know him, Dr. KG Umesh. KG Umesh hails from Bangalore, and he's the president of the National Veterinary Foundation, a postgraduate in clinical medicine, and he has been a former faculty at the Bangalore Veterinary College. Dr. Umesh is a well-known consultant, and he has been providing highest quality of technical support and scientific communications and veterinary education within Asia. He has initiated a lot of CPD programs, and most of them are first of its kind in the country, that has provided small animal clinicians with the best experience possible. And because of his huge knowledge sharing as well as clinical education, hands-on labs and workshops, so on and so forth. Dr. Umesh is currently working as a small animal consultant in a private practice in Bangalore. He has delivered more than 1,200 lectures in national and international veterinary meetings, and he has received numerous awards, including Innovation and Best Teacher Awards. Recently, Dr. Umesh has been felicitated with award for outstanding achievement by the Veterinary Council of India under the Government of India. She has also been a fellow of Animal Nutrition Association as well. He has published a lot of research papers and has written a lot of hundreds of such articles which have been widely read by small animal practitioners. He also represents Asia for the Asian Society of Veterinary Dermatology and the Educational Committee of the World Association of Veterinary Dermatology. Dr. Umesh is a full member of the European Society, the American Society of Veterinary Dermatology, the Indian Society of Veterinary Medicine, and the British SAVA Association. His hobbies include listening to music and reading evidence-based clinical publications. I request Dr. Bapat again to welcome Dr. Umesh to today's summit. Thank you very much, sirs. The third speaker for the day is Dr. B. Nagarajan, again a luminary which all of us know, whom all of us know of. He hails from Chennai in India, and he has been a president of the he is the current president of the Association of Veterinary Dermatology and an administrative member, committee member of the World Association of Veterinary Dermatology. Born in Karur, which is in Tamil Nadu, Dr. Nagarajan graduated from the Madras Veterinary College and went on to start his career as a veterinary assistant surgeon in Kerala Livestock Milk Marketing Board in a place called Palakkad, which is about 40 kilometers from Coimbatore. And since then, he has worked in the Tamil Nadu Animal Husbandry Department in numerous positions across a wide variety of dispensaries, village centers, hospitals, sheep development projects, cattle breeding, fodder development projects, and he did it for about 9 years. And then he later on became a faculty at the Madras Veterinary College, where he taught for more than 3 decades, beginning in 1991. He handled a lot of UG and PG courses, guiding 24 PG diplomas, 10 MBSc students, 4 PhD students, and in his academic career. The entire dermatology ward in Madras Veterinary College has come into existence because of the persistence shown by Dr. Nagarajan. Dr. Nagarajan has authored more than 86 research papers, has been a recipient of more than 12 national awards, and has given close to about 1,200 lectures. Dr. Nagarajan, after his retirement from the Madras Veterinary College, is currently involved in full-time clinical practice at the Balo Multi-Specialty Hospital in Chennai. He's the current president of the Veterinary Association of Veterinary Dermatology in India, which had a very successful meeting last month in Cochin. And he has been a member of the European Association too. He's an executive member of the FASAPAI, and he has also served as ex-secretary of the Asian Society of Veterinary Dermatology and as a past president of the Small Animal Practitioners Association of Chennai. So I would request Dr. Bapat again to welcome Dr. Nagarajan to this summit. Thank you so much, sir. So we start the day's proceeding. I will start it with a corporate presentation of SavaVet. Though most of you know about SavaVet, it's as a formality I need to start it with a corporate presentation. I'm sure more colleagues will join. It's like buying more time so that we start at about 5 o'clock so that more people can listen to Dr. Marcella, Dr. Nagarajan, and Dr. Umesh. Dermatologists never make rash decisions. They never make rash decisions, right? Dermatologists never make rash decisions. But again, most of the decisions that dermatologists take is because of an animal being rash, having rash, or being itchy. Enriching lives of companions has been at the core of SavaVet. Ever since we started this business unit 10 years back, this is what we wanted to do. And that's how most of the products of SavaVet has been placed. They help either to improve the life of the patient or in order to make the life of the pet parent and the patient better, and also to extend the life of the pet, to lengthen the life of the pet. And that's how we think that we are able to enrich the lives of companisons, and through them, the entire community also benefits. Our strengths are fourfold. The most important strength that Savavet has is in providing quality pharmaceuticals. And each one of our 49 brands that we have at this point in time, we certainly feel that they fulfill this core strength. The R&D capability that Savavet has is something that we are very proud of. Not many veterinary pharmaceutical companies in India have an R&D facility. We are very proud that we have an R&D facility with about 45 scientists in Pune who are able to formulate products which are going off patent as well as newer formulations. The pan-India presence of Savavet is very important. We meet about 5,500 veterinarians in small animal practice across the country on a monthly basis, and they are met by the largest and the most trained team in this industry. So close to about 120 people work with me in meeting these veterinarians. The brands that you have trusted for the last 10 years, like Fiprofort Plus, Safeheart, Carodil, Lisabin, Kivor Plus, they remain one of the most important brands of Savavet. So our incredible dermatology range also provides veterinarians with infinite possibilities. To start with, we have got Fiprofort Plus, and Fiprofort Plus has been used by veterinarians for the past about 10 years now. We have dispensed close to about 18 lakh dosages across the country over the last 10 years, and it's still the only spot on with evidence of safety and efficacy with an Indian study. I was seeing Dr. Gatne, I'm sure the next slide he would love to see, because when we did the trial of Fiprofort Plus in Bombay Veterinary College, and we looked at the reproductive potential of ticks after exposure to Fiprofort Plus, we saw that there was a tremendous decrease in the amount of eggs laid by the female ticks after exposure to one Fiprofort Plus spot on. Similarly, we also saw that the output of eggs, reduced by about 73%, and the number of larvae which was hatched out of these eggs came down by about 72% after one single spot-on treatment with Fiprofort Plus. And we continuously recommend veterinarians to use monthly spot-ons on every month so that the tick load and the free load intensity comes down. So Fiprofort Plus still remains one of the most recommended combination spot-on by veterinarians across the country, primarily because of 3 reasons. It provides enormous amount of safety. Less than 5% of Fiprofort Plus actually gets absorbed in the bloodstream, so it is very safe for the pet as well as the pet parents. It is highly efficacious, as studies have shown, and it also provides incredible convenience while applying. I'm sure at many points in today's summit we'll be talking about cyclosporin, and we always say that patience pays with long-term results. So atopy is like a stock market. It will go, it will come down, it can be bearish, it can be bullish. But again, at any point in time, a patient with atopy always remains a patient with atopy. You might not get the signs and symptoms, but that doesn't mean that the patient is absolutely normal. At one point in time, when there are triggers, the patient will definitely show signs of pruritus. So cyclosporin has been with Sava for the last about 10 years. It is the most prescribed cyclosporin brand in veterinary specialty. It has been indicated by US FDA for the medium to the long-term management of atopic dermatitis. So we have a lot of options to do today in India in terms of managing patients with atopic dermatitis in the short term. But again, in the medium and the long term, cyclosporin is one of the most widely studied drug with 2 decades of pharmacovigilance studies. We recently also labeled cyclosporin for use in cats. I'm sure, again, we will be talking about the use of cyclosporin in cats, or we will be talking about allergy in cats in a much broader manner. So you could use cyclosporin, which is available now as HMUN-C, in a 30 ml bottle, which is a new SKU that we have launched, and it is specifically suitable for patients with allergies and in cats. So we all know that the dose is about 7 milligram per kilogram body weight, unlike what we do in dogs, which is about 5 milligram per kilogram body weight. And it is primarily used for chronic allergic dermatitis in cats, though the term keeps changing, like feline atopic skin syndrome and things like that. I'm sure Dr. Marsana will touch upon that. But again, this is the basic indication for which cyclosporin has been used in cats. And we also recently launched selamectin. It's about 8-9 months that we launched selamectin. And I'm sure we are not the first to launch, and you have been using selamectin for last 3-4 years, I guess. And if you've used it, you have used the original research product too, you have used a lot of branded generics too. But again, since we came later, we thought we should do something different. And when we looked at the way selamectin works, and the one thing that all of us need to understand is that selamectin is a much more oily formulation as compared to fipronil. So when you pack selamectin into the conventional polypropylene polyethylene tubes, there is a very high chance that the degradation of selamectin will be faster. So which basically means that if I give you a selamectin tube with a shelf expiry of about 24 months, at any point in time you do an assay and you see, so if selamectin is packed in the conventional polypropylene polyethylene tube, the assay results will keep coming down. So it will not be 90% of label claim, it will keep coming down. And that basically is the reason for getting very high variability when you use selamectin, both between brands and between the same brand used at different points during the shelf life. So we went back and then we saw what can be done, and this is how it is. So we brought Celafort in a polyfoil tube as compared to the other selamectins that we have in the market. Even if you compare the original research too, the selamectin comes in a very attractive, award-winning dispensing sign. So this design is now one of the most widely used in veterinary pharmaceutical industry. Even few international brands have also got a similar kind of tube, and that is primarily to improve the barrier, right? So we don't want the active pharma ingredient to lose the intensity with which they can work. So this comes as a single tube. The cap can at no point in time get detached from the rest of the body. So you don't need to punch it, you just need to twist it and the liquid flows out. So at only one time during this entire usage that the orifice opens, that is when you twist the cap. Other than that, at no point in time, the selamectin which is packed inside is ever exposed to the environment. So with this, we are able to give a lot of good quality and thereby better efficacy. And the design itself is very aesthetic. You have a pre-printed tube, which I get it from Switzerland. We manufacture it in our facility in Gujarat, but this is how it comes. And it is having an aluminum coating inside and a polypropylene outside. So that helps to keep selamectin intact. We also have Felintra. Since we are talk about only dermatology, I will constrain my presentation only to the dermatology brands that we have. We have got an itraconazole 10 milligram per ml, which is primarily indicated by US FDA for the treatment of dermatophytosis associated with Microsporum canis, and we indicate it in cats. We also have a tacrolimus ointment, 0.1%, and this is primarily for lesions associated with canine atopic dermatitis, and it can be used for a lot of other indications like pododermatitis and also for perianal fistula. We also have a shampoo called Perdruff. It has a pyroxenolamine as an active ingredient. I'm sure all of us have been using a similar kind of product for a long time now. So, but again, Perdruff is much more than a shampoo, primarily because it also contains 7 botanicals in the formulation. Now, what are these 7 botanicals? We have got watercress extract, we have got ivy extract, sage extract, common soapwort extract, burdock extract, seaweed extract, and lemon peel. All of them not only help in improving the skin, it also help in nourishing the skin. So after a bath, you also have a high chance of dry skin. So this avoids that. So you can use it multiple times without dehydrating the skin of the pet. So, so it combines antifungal properties of pyroxenolamine with the natural goodness of the 7 botanicals that it has. We also relaunched W Shield, which is a herbal ointment. which also contains, neem extract. It also contains eucalyptus, turpentine. So this can be used in common practice as a herbal wound healing ointment too. We have Stafban, as all of you know, which is mupirocin for superficial pyoderma, and which is one of the biggest selling mupirocin brands in the country. We also have cephalexin for skin infections, and we have a comprehensive portfolio of 9 antibiotics. Now, no company has 9 antibiotics with them, out of which 5 are oral antibiotics like enrofloxacin and ataxin, amoxiclav and toxamox, clindamycin and bioclan, and we also have 2 topical ointments. One is Stafban, the other one is Stafban F, which comes with fluticasone. We also have 2 injections, doxypet mono and promeseptazo. And we also have ketoconazole tablets, which is for mixed fungal infections, malassezia and things like that. And we also have a ketoconazole chlorhexidine shampoo, which can provide Z+ security in patients who require an antifungal along with an antiseptic action. We also have Chlorhex, which is 4% chlorhexidine. I'm sure, again, you will listen about chlorhexidine multiple times during this presentation. And we also have miconazole with chlorhexidine, which is a Betachlor M spray. And our journey continues. And this year, we'll also launch close to about 3-4 dermatological formulations. Again, few of them would be first of its kind in the country. And I'm sure you will be able to find need which is already there, and you would be able to use those brands. So thank you very much for your patient hearing. I would now request the first speaker of the day, Dr. Rosanna Marcella. Yeah. Yeah. Yeah, please, sir. Now is also fine, sir. Absolutely. So the 12% in cats has never been studied. So what normally companies tend to do is that, so you have got selamectin in multiple strengths. You have 6% in cats and 12% in dogs. And the volume of selamectin, which is actually in that tube, ranges from 0.5 to about 3 ml in dogs. So 0.5, 1, 2, 3. And in cats, you have got 0.75 ml, which we have it in country. So normally what companies do is they try to get the same tube done for different, and they tell the private labeling companies that you give me 3,000 tubes of this as dogs and 3,000 tubes of that as cats, which is fundamentally wrong, because the studies of selamectin in cats has been with 6%, and that is the strength it has to be used. So people say that, okay, I'm not giving 6%, now let me reduce the volume, then give 12%. That's not right. That's not right. You cannot have only dal and say, no, I don't want dal, I will have less amount of rice. It doesn't work that well. So reducing or increasing the volume and trying to change the concentration is not right. Any other questions, sir? So thank you so much, sir. I would request Dr. Rosanna to come and make a first presentation. It is on the diagnostic approach to pruritus in cats and dogs.
Good afternoon, everyone. Thank you for being here. Thank you to Savavet for the opportunity to come to India. It's my first time. I'm excited. I'm impressed. And I hope that you will find this information useful for your practice. I included my email address. I am very happy to answer questions that you may have afterwards, or if you need any advice with cases. Feel free to send me an email. I also wanted to let you know that you will have full access to this PowerPoint presentation, so you don't feel compelled to take pictures or write it down. If that's how you learn, that's fine, but you will have all the references and all that information, okay? So the first hour that I have is on diagnostic approach to pruritus in dogs and cats. It's a common presentation, very frustrating, so hopefully this will help providing some basic foundation. So pruritus is frustrating because it's non-specific, right? So there are many diseases that can lead to that, and pruritus is multifactorial and cumulative. There are many different components that in the same patient can contribute to the itch, and in order to be successful, we need to identify these factors. And it starts with a thorough history. There is absolutely no substitution for history, and this is why derm cases may take a little bit longer time, but it's critical to ask a bunch of questions that will allow to properly rank the differential diagnosis, starting with the most likely to the least likely diseases, so that you can kind of either rule in or rule out differential diagnosis. And so there is, I'm going to go over the elements of the history. Then I'm going to talk about the physical exam, starting with the general physical exam and the dermatological physical exam. So as we will talk about it, many skin diseases can look the same. And so as we do the derm exam, it's critical to look for primary lesions. So primary lesions can help you sort out differential diagnosis. And unfortunately, the majority of skin diseases have secondary infections added to it. So the infections are always secondary. There isn't such a thing as an idiopathic pyoderma. That's something that we used to say when we had no idea on how to identify underlying diseases. So infections occur for reasons, and we need to figure out what that reason is. And that is our best chance to prevent relapses of infection. So in terms of itching, so I know you're all familiar with this, but just to refresh our memory, each one of us is able to tolerate a certain amount of stimulation without being clinical, okay? That is called a pruritic threshold. This threshold varies from individual to individual, and we see it in the clinics with animals that are very excitable and high-strung, and they have a very low threshold for pruritus, and some animals that are very easygoing and kind of like on the lethargic side, and they may have the same type of allergy as a Shih Tzu, but they don't seem to be bothered as much. And threshold is lowered by stress. So you may have a patient that is clinically controlled, and then a stressful event happens, and they become symptomatic again. So it's important as clinicians to identify where the pruritic threshold is for our patient and to bring it below that. So for the sake of an example, let's say that our patient has multiple allergies, and that's a common situation, right? Because if you're genetically prone to allergies, you're not going to have just one, particularly in a hot climate like here, which is very similar to where I practice, which is Florida. You're going to have a multitude of allergies. Allergies to insects, allergy to a variety of pollens, and sometimes allergy to foods. And on top of that, you have your infection. So let's say that the red line is your threshold. And so at that point, you have piled up enough of these factors that you're above that threshold, so you are symptomatic. So as a clinician, there are some things that you can more easily treat. Let's say you can get rid of the fleas, and let's say that you can get rid of the infections, and that may be sufficient to bring that patient below a clinical threshold of pruritus. So we constantly play with that threshold, and that is one of the reasons for why the approach to, for example, atopic dermatitis hardly ever relies on one single medication. Most of the time is multimodal. There are many things that we need to do at the same time in order to kind of hopefully bring that patient below that threshold. So with that introduction, let's start with how we deal with these patients clinically. So I started saying the history is critical, right? So history starts with questions like the age of onset. And many times the age of onset is not the age of the patient when you see it, but is when the problem started. Many of these cases have passed around from one vet to the other because people got frustrated, and so if one person doesn't fix it, they go to the next vet. it's important to know where how it started, how it changed, what part of the body was affected first, was it seasonal, and if there was anybody else that was affected as well. The important thing, I believe in starting with common things first, right? So it's very critical in a climate like this to take care of the insects. So an animal needs to be on some form of flea control. So you pick the product that works for you, but it's critical that people are doing something for the fleas and the ticks, and that is the very first thing to do. And then now we have some products that also address mites. So pick the one that works in your hands, but it's critical to address insects and mites in a comprehensive fashion, because there is no reason for us to miss this diagnosis anymore. Then I always ask, what's the response to previous treatments? And with some caveat. In other words, you may have a patient that responds, let's say, to steroids, and there are many things that respond to steroids. That does not necessarily mean that because it responded to PrEP, let's say, you are dealing with an allergic patient, okay? But at the same time, if I have an animal that did not respond, let's say, to steroids, then it's important to consider what are the diseases that are more resistant to that. And in that category, for example, I put secondary infections. I put things like malassezia dermatitis. I put allergies like food allergy. Those are things that typically don't respond well to steroids. And this is an important consideration when we think about, quote, treatment failure. You know, there is an opportunity for us not necessarily to increase the dose or go stronger, but to think about what am I missing. And so secondary infections are a common cause for treatment failure. So that is part of, some of the questions that I ask. Then, you progress in doing a thorough physical exam. And again, I always look for primary lesions. So a common primary lesion in pruritic skin diseases are papules. And so I look for papules and I look for the distribution. Why is this critical? Because, for example, if I have a dog with pododermatitis, just to make an example, it's important for me to figure out, one, is it papular or not? Because if I think of contact allergy, I do have primary lesions like papules. If I have atopic dermatitis, many times I don't have a papular eruption unless they are hostasmide allergic. Also, I look, and we'll talk about whether it is bottom or top or both. So something that's primarily ventral is more of a contact as opposed to something that is dorsal, which is self-inflicted, like atopic derm. So paying attention to the distribution of the lesions and the type of lesions can give you some clues on what the underlying disease may be. So I make a list of problems, and I make a list of differential diagnosis, starting with the most likely to the least likely. In other words, if there is a disease that can explain them all, then I rank it higher as opposed to giving multiple diseases at the same time. And then there are some basic things that I do in most cases. I still do skin scrapings. Okay, and that can be superficial or deep depending on what you're going after. Let's say Sarcoptes versus Demodex. And I definitely do cytology in every single case. And I know you guys are busy. You see many cases every day, many times running from one room to the other, right? But there is no substitution for cytology. Maybe you can teach, your technicians to do it, because you may not have time to sit at the microscope. But the point is that there are many diseases that you can somewhat diagnose or at least have a clue based on your cytology. And if you don't do it, you miss it. For example, fire ant bites, let's say insect bites, loaded with eosinophils. Or another one, let's say that is a pemphigus case, and so you may find the acantholytic cells. Or even deciding what kind of bacterial infection is cocci versus rods, or yeast versus bacteria. These are all things that you cannot just guess looking at it. So cytology is cheap, is fast, and can give you a lot of information. Fungal culture in cats, I strongly recommend it, particularly if the animal is indoor-outdoor or lives with other animals. There's no reason to miss this diagnosis. So in terms of how to rank these diseases, I made some example based on distribution. Let's say that the itching is primarily face. Of course, you want to think about allergies, starting with environmental, food, and we'll talk about, what is more likely and less likely. Cats with flea allergy is typically on the face, but dogs can get hot spots on the side, the face, and that is most of the time due to fleas. I always still put Demodex on my list because I can tell you that I've had cases referred for allergies because they had a red itchy face and they turn out to be Demodex. And so those are the common things. And then you can go down the list and have less common diseases like, let's say, cutaneous lymphoma. And always add secondary infections. When you're dealing with cats, again, you can have allergies, then mosquito hypersensitivity when they have those eosinophilic, highly pruritic lesions on the nose. That's a classic location for mosquito hypersensitivity. Of course, mites, whether it's notoides or orthodactys, and then, secondary infections. So I put together some images, okay? So itchy face on a cat, okay? So that's the distribution of the pruritus with very different diseases. So one turned out to be a food allergic cat based on, a food trial. The other one turned out to have notoides based on a skin scraping. And the other one had pemphigus based on cytology. So now let's look at what is the clue clinically, okay? So the notoides cat, you can see that has all that crusting on the margin. So it is popular, but the distribution within the pinna is peculiar, right? So if you compare the pemphigus pinna versus the notoides pinna, right? So, and this is true for dogs as well with sarcoptes, so these mites tend to go to the margin of the pinna. So any crusted pinna, you definitely want to reach out for a scarpa blade and do a scraping to see if it might be parasites. Or if for whatever reason the animal is not amenable to the scraping, at least prescribe one of those treatments that will cover the mites, okay? So facial pruritus with a lot of different diagnoses. Pedal pruritus, like I said, you look for the lesions, you look if it's all 4 feet versus the front feet versus the back feet. I'll give you an example. The atopic dog typically starts with the front feet because the pododermatitis most of the time is self-inflicted. So the front feet are more easily accessible. The flea allergic animal typically starts with the back feet because the bulk of the pruritus is the second half of the body, is from the waist down, right? So rump, tail, back legs, back feet, okay? If I have all 4 that start at the same time, particularly if it's on the bottom, then I think about contact allergy. So these are all observations. Of course, it takes a little bit of time, right? You need to kind of pay attention to how the patient looks like. It's not just something that can be decided in 2 seconds, but they can really help sort out differential diagnosis. As far as cats, I just put some images together, okay? So different explanations. So this cat here that has that brown discharge here in the nail bed. Let's see if this works. Okay, here it is, maybe, or not. Okay. I don't see on the screen. But anyway, so the brown, black exudate in the nail bed is typically malassezia. Okay? So that's easy to do cytology and identify, and they can be very itchy. But then one thing about pemphigus in cats is that it causes paronychia. Okay? This is different pemphigus in cats versus dogs, right? So the dog, they get this hyperkeratosis, like crusted feet, but they don't get the paronychia. Cats get the hyperkeratosis and they get the paronychia. And you need to be aware of it so that you can kind of squeeze the nail out and then do cytology, right? So that basically, just by doing, thank you, just by doing the cytology of that material in the nail bed, it will, I already gave you 2 examples on how that can help you make a diagnosis. One was yeast, the other one is pemphigus, right? Okay? And then, you know, another example, you know, the food allergic animal that is basically itchy and is causing damage. So that is self-inflicted, the alopecia is self-inflicted. So pruritus in the ears, we already talked about a few cases. This dog had, for example, papillary eruption, okay? But think about it. So it's all diffuse all over the pinna, and the papules are all the same stage of development. So it looks different from the Sarcoptes pinna that is particularly on the margin, right? So this dog had contact allergy. So again, it's itchy, it's papular, and is uniformly distributed. So again, you will have this differential diagnosis, allergies, but again, you can have the mites on your list as well as the secondary infections. Then moving to cats, okay, you have different presentations here again. You can have the cat that where the lesions on the ears are self-inflicted due to pruritus. Many of them also have a secondary infection. And as we will talk about allergies later, environmental allergies are diagnosed by exclusion, right? So unfortunately, there is no test for it. You have to go through this painful process of ruling out other diseases, right? And so, but they're very common. In my experience, more common than food allergy. And they can cause a tremendous amount of head and neck and ear pruritus. Then you can have other possibilities, like animals that have a lot of exudate in their ear canal. And we do see ear mites, not as frequently as you see them here, but I encourage you to do 2 types of cytology when you have this type of brown-black exudate. One for mites, you know, you don't stain it, you just put some oil, cover slip, and look for mites. And then the other one that you will fix and stain and look for bacteria and yeast. In many of these cases with this brown-black exudate, they end up having yeast infection. And then, you know, you can have other types of infection, like this cat here on the bottom had a staph infection, and that to the point that it became so pruritic that it caused hematoma. And in this case, then the next question is, why did it get this infection? And so you need to work them out for an underlying cause. So in this case, it was allergies. So based on the age of onset, what are the things that we can kind of reflect on? If I have an animal that is very young, I have to think about diseases that don't require a tremendous amount of time to develop. So flea allergy, of all the allergies, is the one that can occur at the youngest age, okay? So less than 6 months of age. Food allergy also can occur very young, but statistically speaking, flea is much more common than food. But if I have a patient that also has, let's say, some GI signs, then I definitely put food very high on my list. And of course, parasites, fungal infection, they can occur at any age, and certainly in puppies or young individuals because they're more immunocompromised. So these are all considerations to have. In terms of older animals, what are the things? Let's say they did not have any issues early on in their life, but now later on they have issues. So I think about diseases that can occur either at any point in time, like food. Food does not follow any rule. So it can start very young, can start very late, okay? So it's one of those things. Or it can be a metabolic endocrine disease complicated by infections. Because endocrine diseases, for example, by themselves are not itchy. They become itchy once the infection occurs. So once again, in the history, the classic history would be that they started losing their hair, let's say with the truncal distribution, and then they get the spots, the owner will describe as, oh, they get the bumps, and then they become itchy. So the itching comes later. They don't start with itching. It's something that they acquire later on. So, like I mentioned before, pruritus is cumulative. There are many things that contribute to it, and so we need to figure out what are the different components. And I'm going to start with infections, because infections are extremely common. And I'm going to start with staph infections. And the last hour today, we're going to talk about antibiotic use and how to deal with this recurrent infections. But for now, just share a few images. So you can have the non-inflammatory mouth-eaten alopecia, like the dog here on the top on the left. So where basically they have the circular areas of alopecia, which basically means folliculitis. And then folliculitis, there are three top differential diagnoses: bacteria, Demodex, dermatophyte. So in a dog, if I have to rank them, bacteria always come first. So anytime you have the circular patches of alopecia on the trunk of a dog, you always want to have a staphylococcus on your list, okay? But you can also have cases of pyoderma that are more inflammatory, like the one on the bottom, right? So you have all these papules, and then you have the collarettes, and then eventually they become like non-characteristic, like the dog on the top on the right. So all this crusting, which is basically a complicated, more chronic presentation. But what I wanted to highlight is that many times people look at lesions like this and they think it's ringworm. But if it looks like ringworm in a dog, it's most likely staphylococcus, okay? So it is infectious, but it's bacterial. And then sometimes they just look like bad cases of seborrhea, right? Because you have all these pustules that dry up, and then they basically look like dandruff. But not all dandruff is the same. So the dandruff or scaling of pyoderma is this large flakes, not tiny flakes, large flakes, because these are pustules that dried up, and so then they start exfoliating, right? As opposed to tiny little scaling that may be more nutritional, may be more due to dryness and other causes, let's say excessive topical therapy. They are not large like this, right? And then you can have dogs that have mixed bacteria and yeast, like for example this one. So you have this hyperpigmentation that can become extreme. So malassezia tends to go on the ventral neck, and you have this like lichenification, hyperpigmentation, and they're very pruritic. And so one tip that I can give you for this case is, if you do cytology, don't do tape cytology. I don't know how you are being trained to do cytology, but there are many ways, right? So what I say to students, so you can go with the swab, you can go with the tape, or you can go with the scalpel blade and then gently scrape, without oil, gently scrape the surface of the skin to collect all that crusting. And then you smear it on the slide, you hit fix it, and you stain it. And if the skin is greasy, that is the best way to collect a sample that will give you much more information. Most likely in these cases will be loaded with yeast. If you were to simply put a tape on it, you're just going to get the top layer and it's going to look like nothing, just a bunch of oil. So the technique for the cytology will determine how successful you're going to be in collecting information that you need. But what is characteristic of malassezia is that it's extremely pruritic. So many of these dogs have a very strong smell. They can be very inflamed and, again, very pruritic. So once more, anytime you have a dog that is 10 out of 10 itchy and it comes to you with a history of not having responded to steroids, Apoquel, cyclosporin, I beg you to do cytology, because there is an infection that is driving all that itch, okay? So just a normal, uncomplicated atopic dermatitis does not look like that. So, and again, so that makes the derm appointment a little bit longer, but much more rewarding at the end. Okay, so now let's go over the various differential diagnoses that I mentioned, right? So we covered the infections. Let's talk a little bit about fleas. I know you know everything, you've seen a ton of it, but I just want to highlight a few important points, okay? So the classic distribution is, like I said, the rump, the back legs, the tail. You know, they do the corn cobbing, they go up and down, you know, with their teeth biting many times, and there's no evidence of fleas. Because typically if the animal is loaded with fleas, many times they're tolerant. If they have very few fleas or sometimes no evidence of fleas at all, those are the ones that are allergic. And those are the ones that are difficult to convince the owner or pet parent, as you say, that the fleas are playing a role because they don't see them, okay? And as a matter of fact, if I want to sensitize an animal to fleas in the lab, I give them a few fleas every few weeks. That's the best way to sensitize them, which is exactly what happens in real life when people do flea control a few times here and there when they, quote, see fleas. So they need to be either or not flea control at all, which then you end up having other issues like, you know, parasite overload, anemia and all that, or they need to be in a climate like this on flea control all the time to avoid exactly that problem. And another consideration that I wanted to share is this. Many times, at least where I practice, people mentally rule out fleas because the animal is on some form of oral flea control, okay, which are great products, you know, you name it, whether NexGard, Brevetto, whatever it is that you're choosing, great product. The point is that the animal needs to take the medication goes in the bloodstream, and then flea needs to take a blood meal in order to get the medication and then drop dead. So that's a good way to control fleas as a general strategy. But if I have an animal that is allergic, I want to prevent the bite. So, you know, otherwise you're going to see no fleas and you're still going to have an itchy animal. So that is important, you know, in those cases to advise the owner to also use something topically. So you want to have something that works on contact and possibly something that has a repellent activity. So for a dog, it could be a permethrin. For a cat, it can be neem oil, but something that hopefully gets the flea off of the animal as fast as possible, okay? Because, you know, the itching can be extreme, as you know, and they can create a tremendous amount of damage in a short period of time, as we see with hot spots, whether it's on the rump, on the side of the head, and so on. Cats do their own thing. They can have miliary dermatitis as one of the manifestations of flea allergy, but they can also get the plaques, which are very, very itchy, and they can get, you know, granulomas, you know, in the oral cavity, like indolent ulcers. And one of the reasons for why cats can have this oral lesions most likely is through epicutaneous exposure, right? So if you think about the grooming habits of cats and how they will be in contact with the fleas on their tongue and their mouth swallowing, this is how they start their allergic response to the allergen, right? Because they are ingesting it. And this is why many times the lesions can be on the tongue, on the palate, but they can be also in other body areas, okay? So lesions on the feet, you think of mosquitoes, you think about insects, and then of course severe head and neck pruritus. Those are all manifestations of flea allergy in cats, okay? So I strongly encourage you to remind your clients that it's not sufficient just to kill fleas on the animal, that the majority of the fleas are in the environment, and so those are the fleas that they don't see. And as annoying as it is to do environmental flea control, that is the key of success. It's critical to, again, get through the history, the necessary information to learn what kind of environment the animal is in, you know, whether they have carpets in the house, whether they have a yard, what kind of exposure they have, because failing to address that will lead to treatment failure in addressing the fleas. Okay. Moving along and talking about mites a little bit, let's talk about scabies. So scabies is an extremely pruritic disease. The vast majority of the time, as I'm sure you know, part of the pathogenesis of pruritus with scabies is hypersensitivity, right? So if I have an animal that is loaded with Sarcoptes, which is typically young animals, they are not very itchy. But the vast majority of adults, they have become sensitized to Sarcoptes, so they can have very few mites and be 10 out of 10 itchy. And Sarcoptes has a classic distribution of lesions. So Sarcoptes does not like the dorsum like fleas. Sarcoptes like to go on the glabrous area. So ventral abdomen is a common area. And then margin of the pinna, hocks, and elbows. So that is the classic presentation for Sarcoptes. Okay, so if you look at this dog and you can see the ears, the ventral abdomen, this was a shelter dog, and the dog housed in the same cage with this dog had the same distribution of lesion, you gotta think about Sarcoptes. Now Sarcoptes does not survive very long in the environment, so we don't have to kind of go crazy with environmental decontamination, but you need to treat everybody that is in contact. Cats can get notohedris, which is like the feline version of Sarcoptes. Again, extreme pruritus that focuses on the head, on the pinna, and we talked about the margin already. And so again, this without any piece of information could be a lot of different differential diagnoses. You know, if I had a cat that didn't have the obvious margin of the pinna, like the one in the picture, I could think of autoimmune diseases, right? You could think of pemphigus, right? If you did not know anything else, right? But if you have the history and you look at the distribution of the lesions, then you start ranking your differential diagnosis. Now, some cases of pemphigus can be itchy, right? Because pemphigus, you can have some cases they're neutrophilic and some cases they're very eosinophilic. This is true for dogs and cats. And the ones that are eosinophilic, they can be very itchy. But you want to start with the common things first, right? So you want to think of mites and get them out of the list before you start thinking of less common diseases. So I encourage you to scrape these cases, but in the event that you don't find the mites, because maybe they are hypersensitive to it, so that's how they control the number. They can have severe signs with low number. Just go ahead and treat it. And I put the list of products that I have available, but the ingredients are basically the same. The name might be different, but you know, we use a lot of selamectin, we use moxidectin, and then, you know, the newer products. So whatever it is that you have in your practice that works for you, as long as you roll it out. Demodex is another differential diagnosis. We think of Demodex as non-being itchy, and many times it's not, but sometimes it is. Sometimes it's very inflammatory and it can be itchy. So, you know, one of the slang terms for demodicosis is red mange. So it can be very inflammatory. And so it can be, again, on the feet. So I encourage you, anytime you have a case of pododermatitis, I beg you not to assume that it's allergy. There's plenty of pododermatitis out there that is Demodex. And particularly when you see comedones, you have to think of Demodex, because Demodex is inside the hair follicle. So when the mites increase in number, the follicle gets filled and dilated with mites and then has that black appearance, like blackheads. And from the distance, it then gets that gray looking appearance. And when you look up close, then you see that it's made of little comedones. That is the telling sign for demodicosis. Now, other differential diagnoses for comedones, as a general thing, are endocrine diseases, right? Endocrine diseases and actinic damage they can show up with comedones. But first and foremost, particularly if it's on the feet, think about Demodex. And so I put this picture of this patient that was referred for allergy testing with the assumption that being a bulldog and being red and itchy had to be allergy, later to find out that instead had Demodex. So easy enough for to roll it out by treating it. If the patient is too fractious and cannot be scraped or bothered with it, just prescribe one of these products to basically get it out of the list of differential diagnosis. Cats can get Demodex as well, as you know. There are different kinds of Demodex mites, but one is the superficial contagious Demodex. So Demodex gatoi is short and chubby and is on the surface. So it does not live in the hair follicle and is very pruritic and very contagious. And it can induce this self-inflicted alopecia. So there are many differential diagnoses for this non-inflammatory self-inflicted alopecia, flea allergy being one of them, right? And Demodex is, so there are many things to go over the list. But one important consideration that I would like to increase your awareness, many times people make the assumption that all this alopecia is psychogenic because they don't see inflammation in the skin and they don't see primary lesions. But very few are indeed psychogenic. The majority have an underlying cause for pruritus. And the fact that they're not inflammatory has everything to do with the style of grooming of that cat. So some are very aggressive and they induce lesions, and some just pluck the hair. That's how they express their pruritus. But they have a very good reason for that behavior, and so as clinicians, we need to figure that out. Other differential diagnoses, dermatophytes, like I mentioned for cats, I strongly encourage to do a fungal culture in patients, and so to make sure that we don't miss it, because if we make an assumption that is allergic and then let's say we prescribe steroids, then you can worsen dermatophytosis. And I put this picture here because a dog was diagnosed with dermatophytes. He was diagnosed with trichophyton. And trichophyton can give lesions that look very similar to autoimmune diseases, right? So if you don't know anything and you are presented with this dog that has crusting on the face like this, it's easy to think of autoimmune disease. And the catch that is even more scary is that dermatophytes can cause acantholytic cells, because the acantholytic cells can develop in a variety of ways, right? So the pemphigus way is that you have antibodies against the desmogleins, and so the cells become detached and you have acantholytic cells. So that's the autoimmune way. But it's also true that any time that you have a severe accumulation of inflammatory cells in the epidermis, that you can have with a severe pyoderma, you can get it with a severe contact allergy, and you can get it with a severe dermatophytosis, you can get acantholytic cells. And so if you don't culture these cases and you do cytology and you see these cells, you say, okay, looks like pemphigus has acantholytic cells, the people don't want to pay for a biopsy, let's go ahead and get started with some treatment, and you prescribe steroids, then you're going to make it much worse. Right? So think about the possibility that it could be dermatophyte. And so the way to address it would be to do a fungal culture. As you, I'm sure, know, Wood's lamp is for M. canis primarily, right? And not even for every single case of M. canis, but certainly not for trichophyton. Trichophyton would not be positive on a Wood's lamp, so you have to culture it. And another thing to remember, if you keep these cultures in your practice and you don't submit it, the rule is you want to see a change in the color of the media at the same time that you have the growth of the dermatophyte. So the dermatophyte should look white and fluffy, not brown, not green, not gray, okay, white. And typically within the first 10 days, and you have at that period of time, you have the change of the color of the media. If you don't check the plate, you forget about it, and then weeks later, open your drawer and look at the plate and it's red, then you cannot say it's dermatophyte, particularly if it's not white. Because what happens is that other fungal organisms can change the color of the media, but they do it later, okay? So I can tell you that I've had a lot of cases referred with the wrong diagnosis of dermatophytes because of that situation. So to summarize, check your plates every day, and then make sure that you also do an identification of the dermatophyte, which is very easy. You can get lactophenol blue, and then basically stick a tape on your plate, put a drop of the staining on your slide, and then put the tape on it and look for the morphology of the macroconidia, okay? And so that's how you would identify dermatophytes, so that you know for sure you have the right diagnosis. All these things, you don't need to be a dermatologist. You can do it, you know, in your practice, okay? So let's say now we're going down the list, and we have ruled out infections, parasites, fungal infections, and now I still have this non-seasonal case. So I consider a possibility that that might be a food allergy. So what are the things that we want to remember about food allergy? Like I mentioned before, it can look like anything. It can start at any age. Okay, let's start with this. And so that makes it a bit challenging. Importantly, you don't need a dietary change in order to think about food allergy. Matter of fact, the majority of the cases develop a food allergy to something that they have ingested for a long period of time, because it's the whole concept of allergy, right? So you need to have exposure over time, and then you develop a hypersensitivity. So that takes time, okay? In my experience, food allergy is not very common, okay? Having said that, if you have non-seasonal clinical signs, you gotta do a food trial, because it would be silly to miss it. But it's not as common as maybe some companies make you feel like it is, okay? One characteristic of these cases, they come with a history of not having responded, let's say, to the steroids, the cyclosporin, the apoquel, and so on, because food allergy does its own thing, okay? And we know very little about the different mechanisms. It's probably a mixed bag that we kind of lump under this term, food allergy, but we really don't know what we're doing with it, okay? So there's some that just don't respond to treatment, okay? Some may have GI signs. If that is the case, it makes it easier to think about it, but many of them don't have GI signs. Some look like atopic dog, you know, so they have, a matter of fact, food is a trigger for atopic derm, okay? But some have other distributions or manifestations. And so with that introduction, I want to spare 2 seconds, and I'll talk more later. The term atopic dermatitis. We equate atopic dermatitis equal allergy to environmental stuff, right? That's how we have been trained. But it's also true that atopic derm is a clinical syndrome that has different triggers. And one of the first triggers, particularly in human medicine for atopic derm, is food, okay? So food, quote, allergy can look like atopic derm. But if you have a different type of hypersensitivity to foods, let's say type 3, you will get vasculitis instead. So atopic, allergic manifestation of food that looks like atopic derm is just one of the manifestations of it, okay? You can have dogs that present with hot spots, and then, of course, they get all the secondary infections that make everything more complicated. So some images, you know, so you look at itchy face, itchy feet, and they look clinically indistinguishable. Many of them have otitis, And otitis may be one of the recurrent otitis, may be one of the first signs of it. So one difference between the atopic dog and the food allergic dog early on could be one of these, that the recurrence of otitis for the atopic dog due to environmental allergy is more of a seasonal occurrence, right? So the weather changes and they start getting infection. And then assuming that you fix the infection and the weather changes, then maybe he's done for that year until the next allergy season. While the food allergic animal does it all year round. Every other month gets an infection. That's difference number one. Difference number two is that the environmental allergy is outside-in disease, right? So it's an epicutaneous exposure. So when I do my otoscopic exam, I see that the pinna is pretty red, vertical canal is pretty red, and then I get to the horizontal and things start to look better because it's farther away, unless it has a secondary infection. With the food allergic patient, is more of a systemic disease. So the whole ear canal is red, okay? So these are little things that can kind of help you rank diseases. But the point is that food allergy can look like anything, can be non-specific and very pruritic. And if I have a cat, then it can look like any manifestation of the eosinophil granuloma complex. Now I have some references here that I put in this presentation. This is one review article that was just published in JAVMA. I encourage you to download it. There's a special issue that is all on skin and has a lot of good review articles. Hilary Jackson is an excellent dermatologist. She has devoted a lot of time studying food allergy, and it basically is a summary of what we know, and so I encourage you to get it. But the bottom line is that we don't have a test for food allergy. No matter what serology test is advertised for it, it doesn't work. So you cannot make a diagnosis based on those tests. So you're stuck with the food trial. And when you do the food trial, you have a couple of options. One is that you go with the idea of the, quote, novel protein. And the idea is that you feed something that the animal has not had before, because in theory, you should not be allergic to something that you never had before, right? That's the whole concept of allergy. Or you can go with the concept of the hydrolyzed diet, okay? So if you go the route of the novel protein, then you make your dietary history and you want to select something that is a, quote, clean diet, that is, quote, limited ingredients, right? So they just have one source of protein, one carb, no additive, no other stuff, okay? Now, the catch is that we have now discovered that you can have patients that develop IgE against certain components in the meat that are conserved across species. So that sadly, you can have similar allergen in fish and chicken, and then they do lamb and grain and a variety of things. So long story short, this whole concept that you cannot be allergic to something that you never had before is flawed. It's something that we assumed, sounded like a good assumption. But the point is that you may have a patient that does not respond to your novel diet, and it may be because it's allergic to that component of the meat that is conserved across species. So that let's say he had chicken all his life, and now you move it to a fish-based diet, but this is the allergen that is conserved and is still not responding. You have to be unlucky, but I mean, it's possible, okay? Then the other strategy is go with hydrolyzed. So the concept of hydrolyzed is that you chop this protein small enough, and this molecular weight comes from human medicine. We have zero idea what the ideal weight is in the dog. And this also because in children, the primary type of food allergy is type 1. Okay, so the idea is that if I make it small enough, is too small to be able to cross-link 2 IgE bound on a mast cell, right? So the concept of type 1 hypersensitivity, you have your mast cell, you have your IgE bound on a mast cell, and in order to have mast cell degranulation, you need to bridge 2 IgE. So if this is too small, it will not be able to, if the red bar is small enough, it will bind to one IgE but not the other. Therefore, you don't have mast cell degranulation, okay? That's a whole premise of hydrolyzed diet. So I am making an assumption that my patient has type 1 hypersensitivity. And this obviously does not hold true if your hypersensitivity is type 4. Because matter of fact, the allergen of type 4 is a very small allergen. So small that it needs to bind to a protein to become allergenic. It's the whole concept of haptens, right? So if I go down the route of hydrolyzed diet, I'm assuming I know my patient has type 1, which obviously I don't know. And on top of that, I need to select a diet that is extensively hydrolyzed, because we have learned that if you just do partial hydrolyzation, you're gonna miss those cases, even the type 1 hypersensitivity cases. So the moral of the story is that there are many diets out there that claim to be hydrolyzed, okay? I don't know the brands, well, I have seen the names, and I know you have a lot of hydrolyzed diets here, but I could not find any information about the size of the peptides of these diets, okay? And that makes a difference, because if it is hydrolyzed but not hydrolyzed enough, you are not even gonna be able to diagnose your type 1 hypersensitivity cases. And even with extensive hydrolyzation, we do know that there are some patients that fail, even with a type 1 hypersensitivity. Okay, so Thierry Olivry published this review years back, where he had this colony of Maltese that were sensitized to chicken, and it was a type 1 hypersensitivity, and then they fed them ZD, and there were still some of them that flared with a type 1 hypersensitivity. So the hydrolyzed diet, when you use it for diagnostic purposes, has a lot of limitation. You may be lucky and your patient responds, great, but if it doesn't, you cannot roll it out, sadly, okay? What I have found is that many times people make, quote, diagnosis of a food allergy that may not be a true food allergy, okay? So what are the things that we need to be mindful when we do this food trial? First of all, we need to get rid of the infection, right? Because if it's itchy because of the infection and I didn't fix it, how am I gonna be able to evaluate the pruritus, right? So that needs to be out of the way. The other thing then I'm going to monitor is the residual pruritus, and then whether I'm able to prevent a relapse of an infection. That's the whole concept, right? So in order to determine this, I need to know what's the relapse rate of that patient. So in other words, on a routine basis, in his history, how often does it get this pyoderma? Is it every other month? Is it twice a year? Is it every other week? What is it? Because that determines how long my food trial needs to be. If the infection comes back every other month, let's say, which is common, then my food trial needs to be longer than 2 months, right? Because if I go 2 months, it's just about the time to have another bout of pyoderma. So when in the literature says, oh, the ideal duration of the food trial is, quote, 8 to 12 weeks, quote, it's because many patients kind of are in that interval, but you need to look at your patient. Is that 3 months? Then you need to go longer than the 3 months. Is it 4 months? You need to go longer than that in order to assess that. And then how you re-challenge, okay? Because just having an improvement when you fix the infection and the fleas and so on, that does not make it a food allergy. You need to re-challenge it and demonstrate then it gets itchy again or has a relapse of signs. How quickly would that occur? Well, it depends on the hypersensitivity, right? So if I am dealing with a type 1 hypersensitivity, it should be fairly quickly, right? So the same day, okay? If it's a type 4 hypersensitivity, it should be the next day. Now, but there is the whole concept of threshold, right? Depends how bad are you, okay? So in a retrospective study looking on average, what is the amount of time that it takes a food allergic dog to become obvious from the clinical standpoint, it is up to 7 days, okay? So assuming that some are really severe and that you will notice right away, and some are not so bad, that it takes a little bit longer, because when people re-challenge these cases, they use the bulk of the diet that you're using for the food trial as the main meal, and then you give a handful of the quote all diet, okay? So if you're really bad, a handful is enough, okay? But if you are not so bad, maybe the first few meals you can still be okay because you have not reached that famous threshold. But the point is that if nothing happens in that week, and then it's not a food issue, okay? Now, let's talk about the environmental allergies or atopic derm, okay? So I mentioned that there is no diagnostic test, sadly, okay? Because I can do a serology test in an atopic dog, and I may not have a ton of positives, because you can have atopic dermatitis that is, quote, non-allergic, and I can have a normal dog or a dog itchy for another disease that has positive results on an allergy test. Okay, so let me go over this for one more time. You can have atopic derm that is not allergic. How is this possible? Because the skin of atopic patients is not normal. So you can have red, itchy skin in the absence of a sensitization, and that is typically the first stage of atopic derm. Then, over time, because your skin is not normal and you get exposed to allergen over and over and over, the fact that your skin is not normal means that that allergen is going to be processed to make IgE and not IgG, because your skin is not normal. So if I want to sensitize an animal in the lab, what I do, I tape strip the skin, so I damage the keratinocytes. Then I put some allergen, and the keratinocytes that have been damaged, they're going to promote, they're going to release certain cytokines, TSLP and all that good stuff, so that they're going to say, I want to make IgE. And this is how you sensitize a dog in the lab. In real life, the atopic dog starts with bad skin. So when they walk on the grass, they are going to make IgE. And they're going to make more and more over time because they have more opportunity to be exposed. But early on, they don't have IgE. So they can be clinically symptomatic in the absence of IgE. Okay, that's number one. Number two is you can have IgE in animals that are itchy for other diseases. Think about the scabies dog that is full of, it has plenty of reasons to have IgE, and many of these IgE cause false positive binding, okay? And so, but that does not mean that those are the cause of his itching. So long story short, this serology test or skin test, whatever you use, is not diagnostic, because you can have positive results that are clinically irrelevant. So sadly, your diagnosis is a clinical diagnosis based on the exclusion of other pruritic diseases and considerations of presentation, distribution of lesions, seasonality. And then there is one area of the body that is peculiar for atopic derm, and that is the antebrachial area. And this is across species. This is in dogs, this is in horses, this is in people. So there is something about this antebrachial area. The skin is very thin. The allergen tends to get stuck in the folds and is an area of weakness. Okay, so anytime that you have a patient that looks like this, then you can pretty much rank atopic derm very high on your list. Like I mentioned before, cats also can get atopic derm, and Now it's called atopic skin syndrome, but basically is what in the past we have called atopic derm. And the reason they changed the name is that cats can manifest atopic disease also with respiratory signs. Okay, so atopic disease or atopy is a predisposition toward making IgE. And those IgE can be affecting your respiratory tract or affecting your skin or both. And in humans, you have the so-called atopic march, right? So as a child, you start with eczema, and then later on, you get rhinitis and asthma. Dogs, most of the time, stay in the cutaneous phase, but cats can have asthma, so that you have an atopic manifestation through the respiratory tract. So the ones that stay in the skin form, they call it feline atopic skin syndrome. And again, for these cats, is a clinical diagnosis. And I cannot look at a cat and say, oh, you are flea allergic versus food allergic versus environmental allergic. There's a study, Hobie is the author, that has spent a tremendous amount of time looking at a bunch of cats and based on the pattern, trying to figure out if you can guess what the trigger is, and the answer is no. So it's not that you have a peculiar manifestation of distribution of lesion based on trigger. Now, going down the list of allergy, contact allergy. I wanted to share a few slides with you for an important reason that I believe contact allergy is largely undiagnosed, is a cause for severe pruritus. It can have a distribution of lesions that is indistinguishable from the atopic patient, okay? So this dog has severe pedal pruritus with malassezia dermatitis, as you can see the discoloration of the nails. And these patients come because they don't respond to the steroid, the cyclosporin, the apoquel. So this was referred because it was a, quote, resistant atopic dermatitis case. So severe pruritus on the face, severe erythema, and you can see all this papular eruption that eventually coalesces to this intense erythema. But you can have cases that are not as bad, like this one. You know, again, was referred because she was diagnosed with atopic derm that did not respond to treatment, okay? But she turned out to be a contact allergy dog. And then you can have these lesions on the feet, okay? And so what I wanted to, this one? Here, okay. So what I wanted to, I don't see it. Okay, here it is. Yes. So do you see the little dots here? Okay, so yes, you have erythema, but then you have this primary lesion. Same on this side here. And you see how the erythema follows the pad. These are clues to think about contact allergy. Oops. Same is for this one. So you see the little papular eruption here? That's when you have to start thinking about contact, okay? Again, all these cases were referred because they were non-responding to steroids, apoquel, and so on. So I have in Florida this type of plants. I don't know if you have anything like this. We call it a Commelinensia family of wandering Jew, Tradescantia, jasmine, this plant here, jasmine. They're all very allergenic. So contact allergy is type 4, okay? So you cannot desensitize to contact allergy. You need to avoid it. And the way you diagnose it, you do a patch test. So to compare and contrast, atopic derm is type 1, is IgE, is immediate, and we tend to do the intradermal skin testing, which means you inject the allergen and you want to trigger mast cell degranulation, which occurs within 15 minutes. Contact is type 4, and these are not by pollen. These are is basically the juice in the leaves of these plants, okay? So the classic history is they mow the yard, the dog goes out, so the leaves are all broken, and so they get all this material on their feet, and then the next day, they're itchy. So if you don't know, but you suspect this, ask the client to bring you samples of what they have in the environment, from a little piece of the carpet to whatever plants they have. You can cut in small pieces, put a patch, put it on the skin, wrap it, and then the next day you remove the wrap and you look for the lesions. So the take-home message is that if you were presented with a dog that looks atopic but does not respond to treatment as you're hoping for, consider a possibility that you might have contact. And some of these patients have mixed allergy. They have some classic atopic derm, but they have the contact component. And contact always wins in terms of severity of disease. To wrap it up, another differential diagnosis to increase your awareness of severe pruritus in an older dog is cutaneous lymphoma or mycosis fungoides. So some of these dogs are presented with sudden onset severe pruritus later on in life that makes no sense otherwise in terms of allergy. And they may be red, scaly, itchy. That is one manifestation also in humans with lymphoma. Okay, pruritus, all this lymphocytic accumulation. Matter of fact, we do know in dogs that if you have a chronic history of atopic derm, you are much more likely to develop lymphoma later on in life, because atopic dermatitis is a disease of chronic lymphocytic stimulation. So over years and years of antigenic stimulation, you go from inflammatory to neoplastic. So if you have patients that you've been managing for a while and life was good, and then at some point they stop responding, I encourage you to take a biopsy to make sure that you're not missing lymphoma. And then, of course, some are more obvious, you know, right? They had that gingivitis, the plaques, and so diagnosis is easier. But again, some manifest with pruritus and scaling. So to summarize what we discussed so far, I encourage you to start with a thorough history and a physical exam. Make your differential diagnosis based on the list of problems that you have, and start with your initial test. Start with your scrapings, start superficial, and then decide whether you want to do the trial with treating for scabies or not. The deep skin scraping, looking for Demodex, and of course, if it's positive, you need to treat it. Your fungal culture, your flea control, your cytology to address the infection and treat for it, and then reevaluate and see what is left. At the recheck appointment, you have a couple scenarios. You can have a case where it is no longer itchy. It means that the infection that you treated was due to an underlying disease that by itself is not itchy. So you will go down the route of, let's say, endocrine diseases, just to make an example, okay? Another scenario is that it's still itchy and you still have a primary papular eruption. So at that point, you need to think about what can cause papules. Scabies, for sure. So if you have not treated, you should. Food, for sure. So you want to go down the route of food trial, and then you have either the patient that resolves or the one that doesn't. And if it does resolve, then you want to re-challenge. And if it doesn't recur, it might be an atopic dog that went out of season. It was not a true food allergic dog. This is important because at least you know that he's going to flare again next allergy season, and you can prepare the owner for that. Another option is that you have a contact allergy case. So if I have a dog where I think contact versus food, I always rule out contact first. Because contact, if I do avoidance, assuming that the animal has no infection, if I do avoidance within 2 weeks, 10 days, 2 weeks, I have a brand new dog. So it will respond much faster than any food trial, okay? So wash it, put a t-shirt, and then at that point, if you have your diagnosis, then you go down the route of your patch test to figure out what to avoid exactly, okay? Other possibility is that you still have a persistent bacterial infection. So we'll talk about this in the last hour today, and how it is important to do culture sensitivity and pick the right antibiotic. And then maybe you're dealing with a patient where lymphoma is a differential diagnosis, so you may have to do a biopsy. And that will be determined based on your index of suspicion. So to summarize, dealing with these cases takes a little bit of time. You can do all this without being a board-certified dermatologist, just by being systematic, going down the list and ruling out diseases. But the bottom line is that if you don't have a clear diagnosis, your chances to successfully manage these cases is limited, because you're going to be stuck with symptomatic treatment, which many times is going to fail. So I strongly encourage you to get to the bottom of it and make a diagnosis. And I want to leave you with this slide. I hope that many of you are going to come next year to the US, where it's going to be the next World Congress in Boston. And I understand visas are an issue and they're slow, and I hope that you can plan in advance and join us. And I know I'm done with time, but if you, can I take a question? Yeah, okay. No questions?
We'll take 2 questions.
Yes.
So since Florida and Bombay possibly share similar climate, in your experience, have you seen any allergies to sunlight and sun?
Not allergy per se, but we definitely see diseases that are triggered by UV exposure. So UV is inflammatory, and so definitely we see infections that are triggered by the fact that you have inflammation. We see actinic dermatosis, but chronic changes that will eventually then go in precancerous changes and stuff like that. And UV also precipitates autoimmune diseases. So like pemphigus erythematosus, discoid lupus, these are all triggered by UV exposure. So UV definitely triggers skin disease, but not necessarily in the sense of allergy per se. Yes.
The role of ivermectin in cats.
I don't use ivermectin in cats anymore.
Because still here we have a lot of only accessibility to selamectin and imidacloprid as spawns, but would you be of opinion of use of ivermectin in cats?
No, I discourage people from using ivermectin in
Just wanted to
cats.
reconfirm that.
Yeah, I know the older books had that, and I think there was a period of time when we didn't have other options. But I think that it would be difficult to justify this choice when we have alternatives. Okay, U.S. is a litigious society, right? So if I have a product that is labeled and is safer and has the right indication, and I pick something that is off-label that has a higher risk for toxicity, and something happens, there is absolutely no way I can justify my choice. Thank you.
Ma'am, we have one more question.
Uh-oh, you come prepared.
Just I want to show some about last week about this. This is the case.
Malassezia. This is perfect. You need to put on the screen. This,
I saw, yeah.
yes, Malassezia, yeast.
And what is treatment or like that.
So we're going to talk, the last hour, we're going to talk about your case, which is classic. This is Malassezia dermatitis, very itchy, and we're going to talk about antifungal treatment. Yes?
Thank you so much, ma'am. I'm sure we have a lot of questions and she will be there to answer them. Before we go to the next speaker, I'll just take a minute. All of us know that the FASAVA Congress is happening in Mumbai in the month of October. We have some videos to show to you. I will start with the first video.
Hello friends, I am Dr.
Give
Makran
volume,
Chavan,
no?
Secretary for FASAWA 23. Hello friends, I am Dr. Makran Chavan. I am organizing secretary for FASAWA 23. It's the 11th FASAWA Congress and first time it is happening in India. I welcome all of you. I welcome veterinary students, their teachers and all the faculty. I welcome vets from all over India, all over Asia Pacific. It's my privilege to invite you and all the members of Federation, all the members of FASAWA, all the member associations of FASAWA and everybody. It will be fun in Mumbai, you will learn and you will enjoy. Welcome to Mumbai, October 23. Thank you.
So the dates are 27, 28 and 29th of October. Now I'll just hand over the podium to Dr. KG Umesh. He's coming here to talk about hyperthyroidism, whether it's a over-diagnosed condition. Just take it up.
This one. This side.
Done?
Yeah. Okay, wait, no, can I just put this one? Yeah. Slide changer.
Yeah, it's that one. So then,
No, they're not put it.
USB sir उसका
no, it went in
This one?
Yeah, this one.
Video. Okay.
Go. तुम जाओ. Yes.
Okay, good evening.
Still not come.
On.
Yeah.
Okay. Okay, so all the time, okay, so I know a lot of still, okay, are settling down. Good evening, everyone. Okay, good to see a huge crowd on the Saturday evening. I know this is a time where we make a lot of money in the weekends, but glad to hear not you're all here to listen, okay, to some of the lectures here. Before I start, okay, I would like to thank Karthik and okay, Sawa team for inviting me, and most importantly to bring one of the top dermatologists, Dr. Masala, to India. And okay, so we always appreciate our take-home messages at every talk, and okay, very strong okay, take-home messages. And thank you, Dr. Masala, for that. Okay, so my talk is probably about 45 minutes or so. Just want to take about okay, our okay, experience with our hypothyroidism in okay, dogs in India, and so how we are dealing it with that. I'm not here to teach something new. I know that everybody is familiar with hypothyroidism, but I want to know that okay, just now I was speaking to Dr. Karkare, said we have been doing the same okay, 40 years. I'm just fed up. You know, I want to do a different approach. Same one, okay, you know, sac cleaning, same thing, different. How long we do that? But we want to do something differently. Yes, okay, we can have a different approach to hypothyroidism and possibly to rule out some other causes. Because just like an atopy, as I said many times, okay, it's a vague symptom. We always get confused. Should I start the treatment? Should I really wait for the test? And okay, what facilities I have in India? And okay, so what's the best I can do in the Indian scenario, considering the okay, you know, the kind of clients we deal with every day. So that's why I put it as an overdiagnosed problem, for the simple reason that it's my experience in Bangalore that I do see a lot of cases come to me, not just atopic cases and all, okay, many cases which turn out to be a simple case of an alopecia for some other reason, with a dog has been on the L-proxine for the years together. Likewise, you see some of the cases of DCM. I've been seeing the dogs on the safe ward for 4 years, 5 years, and diagnosed as a DCM, and just wondering how the dogs can, with the DCM, can live for 4 years. So just okay, to go back okay, to see that what is that we do. So let's start with one of the first okay, case. I don't know where I took this slide from, but definitely the left one, okay, the Daction, which is okay, came to me okay, with that okay, problem of nice alopecia, and definitely the dog is very, very active, super active, and so eating well. So we did all the doctors have previously treated with all the steroids, antibiotics, etc., etc. In fact, in the Bangalore, one of the vet told me after his all the talk, said, why dermatology is so complex? Said, I'll just give a shot of wet log, and I'll give a one Bravecto and an antibiotic and antifungal. The entire dermatology is finished. And if I don't find any response, I'll think of neoplasms. So what do you think of my idea? I said, then there is a definition for what you're doing. I said, it simply is called as a quack. So you're no way different from the vet. So that's where you have to have a different approach. So this dog has been done everything, treated all everything, but this definitely dog it does not undergo, go under the cot or the chair or something. So that just to have alopecia. So what in your think, when you have a case like this, we did a lab work, biochem, blood work, everything came normal. And so no signs of a pyoderma, no signs of a malassezia, etc. Just a nice baldness here all along. So this is an adduction. So what you would do in this situation, ignore it? Or would you do some thyroid test? Or would you really say, and I'll wait and watch? Or probably you'll refer to a dermatologist. Very quickly, so how many of you say ignore it? How many of you raise your hand? Nobody? Okay, hope you're all listening. Okay, so try to take care of your hand. How many consider hypothyroid? Okay, good numbers. Okay, so this dog, so it is not lethargic. Okay, so cholesterol is normal, no anemia, triglycerides normal. Okay, so I told you everything is normal. And this is in a middle-aged reaction. And so this is the one kind of a pattern you see in Dachshunds. Probably when I show another slide with a Dachshund, then probably think of. So there is a one kind of alopecia you see in the Dachshunds. Anyone? Anyone? Okay, science. I said the first word pattern. Pattern alopecia. Not out of it? Okay. So we'll go to the next slide there anyway. So this is a dog, blue Doberman, came with alopesia, developed over a period of time. And I just changed the slide from the Bangalore because I was told that live stream, so that they're going to be the same talk. I thought I want to confuse them. So I just changed the slides here. So this is a dog with a nice alopecia. And as you see that there are some papules as well, erythematous papules, and mildly pruritic. So this also dog has undergone all the treatment possible for in the dermatology, and blood work is normal, and so everything is fine with this dog. And what they notice also, one hint for you that there is slight change in the color of hair. So Doberman, so Dr. Rosella told, when you're taking history, how does the age, breed, how it is progressed, the distribution of the lesions, all matters many times. So what do you think of this one? I've given a clue. Doberman, change in the color dilution, alopecia. So how do we do that? How do you confirm that? So this is how the color change. And so what we did is just a simple test. We do a trichogram. So what you find is a clumping of melanin, right? The simple case resolved with just one trichogram test. Just an example of that. So this is a Judith, which came a week ago. I'll be talking about it later as well. And this dog is absolutely not happy dog, and there is no alopecia, and definitely it has a tail which is little hyperpigmented as well as lichenified. And the dog came because it's dull and has been losing a lot of hair, and also in the other part of the hair. So what you would do in this case? I said it's mentally dull, and so there is no pruritus. And so would you ignore it, or what test you would do that with these clues like this in the history? I know the history might take 40 minutes, but I want to make it short here. So would you do the test for hypothyroid? How many would raise your hand? Okay, fantastic. I think I need not to do any lecture. Okay, so I can go now. So we did the blood test for this. Of course, it came. So just a kind of a screening test, possibly hypothyroid, because it's T4 less than 0.4, and the cholesterol is more than 400. So possibly, So can I just jump into conclusion that, okay, yes, it is a classical hypothyroid? Let's discuss a little later on this one. So we have another Newfoundland, bilateral alopecia, blood work, mild non-regenerative anemia. And we did, of course, only the T4. The reference range is 12 to 9. Reference range, sorry, is 20 to 50. The borderline 12 to 15. And this remaining things are not done. So let me show the picture of this one. So this dog developed the alopecia, okay, on the trunk. And okay, so the important clue is that, okay, the dog undergone a clipping because of some reason they did all the clipping about a couple of months ago, and the hair is not regrown in that area. Sorry? Thermal? So there is no inflammation there, no signs of it is completely non-inflammatory lesion. You are absolutely, it is a post-clipping alopecia, right? Okay, that's some of the things, okay, which really help you in the history. So this is a non-descriptive dog, which I saw in the college, and obese, non-inflammatory alopecia, classical rat tail, and baldness, and pigmentation around the vulva, and the dog has been, again, obviously mentally dull and not active, and it's been losing hair, and no treatment has been done. So would you consider this as a thyroid in the list, differential diagnosis list? How many say yes? Okay, very few. So good, okay, so obviously we did the test, okay, because at the time I didn't have a zoetis. So it came less than 0.5, yes, possibly hypothyroid. Okay, we need to do further test on this. Okay, this is one more case there. So this is another case, again, came the last week for the nail clipping because it had overgrown nails. And okay, so otherwise the dog, they say it's okay, everything is fine, is eating, but occasionally do develop the ceruminous otitis, and it also has a kind of a, the blackish stuff around the vulva, and they keep licking, chewing that area, and okay, sometimes occasionally kind of a recurrent otitis. And okay, it has grown because the owner is not very keen on this dog, but still I kept asking question. When I said, okay, the dog is very happy dog, does it come to you when you bell the ring, or is it happy to come for a walk, etc.? No, doctor, I have other two dogs. They are very, very playful, but this girl, always, if you find it very lethargic, she'll never get up from the place, always sleeping. So would you consider this a thyroid dog? How many say yes? Fantastic. Okay, so absolutely you're right. So we did the test again. So its T4 is very low, but the cholesterol is normal. Okay, so does it make you confirm that, okay, is that confidently that it is in a thyroid? So let's review on this one. So the last one, okay, the miniature palm. Okay, so it's a physical examination normal, blood work normal, non-pruritic alopecia in the cordomedial aspect on the trunk. So this was a test done from Antec laboratory in the US. That's why you might ask where I got the FT4 done. And okay, so you can see that, okay, it's a 15, okay, it is in the borderline, whereas T4 is about 15, again in the borderline. TSH is very low. Okay, so that gives any clue that it is in a thyroid possibly based on this. It's just because it has a low T4, FT4 still in the borderline, TSH is normal. So would you consider as a thyroid? No? So let's see the picture of this dog. This is a dog which belongs to celebrity, and okay, so this dog came from UK, and the moment I landed in the Bangalore about 6 months later, she said, okay, the Bangalore weather is causing this problem, and started losing hair all over the trunk, and I'm really a bit worried. Okay, so what do you think of this one in your differential diagnosis? The top two. So the important clue is the miniature palm. Flea bite? So the dog is under the flea control. So the owner is very clear on that. Miniature palm. Sorry? I've been hearing that. Yes, absolutely, you're right. So the same dog without any treatment, even though okay, the vet sent this case, started on the melatonin. So about so 2 months later, the hair is all back, and the dog is absolutely happy, and owner is really happy in this one. So what it all indicates, this is another case of alopecia X, And so what do you think of this dog? Okay, so which I talked about the dachshunds, okay, in the first slide. So it has a alopecia in the pinna, the base of the pinna, and the inside is fine, no ear mites, no otitis. And this dog, over a period of time, I don't have this photograph, it developed the alopecia and the ventral neck, and then going towards in the abdomen as well. So otherwise, dog is absolutely healthy, no issues. The dog is least bothered, but owner is definitely bothered about the alopecia on the pinna, on the ears. So what do you think of this breed again on the alopecia? Anyone in the dachshunds? Probably would have seen, if you have seen about 50 dachshunds, you would have seen one of such cases. You heard of a pattern baldness? So that's a case of a pattern baldness there. Okay, so just to give an example, okay, how many cases like this would really confuse you. So this is a dog again, okay, sent to me by Dr. Lloyd, and this dog had a, it had the same problem, okay, said about a year ago, but not this extensive, but it became all right. But again, okay, in the next season, again a year later, it developed the same problem with a patch of hair loss on either side of the trunk. So otherwise, the dog is absolutely normal. Everything, physical examination, blood work, so flea control is good, and it is a non-pruritic. So what is the region of this area called? Sorry? Trunk, but what is that typically called? Sorry? Flank. So that it sounds okay enough a kind of a problem in alopecia you see in dogs. And I said, get the history, it had come last year, it has come back. It's not allergy. Observe it as a non-inflammatory, allergy is inflammatory. You heard of a recurrent? Recurrent. What is the region it's called? Flank. And what is that lesion? Alopecia. Recurrent flank alopecia. Okay, so this is the case again. So without any treatment, so the dog became, okay, absolutely normal. So these are all some of the cases we get, okay, in the practice, and we get always confused whether to do the test, not to do the test. So you also should remember that, okay, as per the paper, some of the endocrine problems which start later over a period of time, they can also develop a second endocrine problem. So probably this is one of the reference I got it, and these are some of the, okay, the references you can see that diabetes, okay, as well as the hypoadenocorticism and hypothyroidism in 22% of the cases, and so on. Those are interested to know much about it because 1 hour and 45 minutes is not okay enough. I need to go to the stage. Okay. Okay, now I can see all my from foot to face. Good, thank you. So those are really interested to know more about endocrine problems. So interestingly, this paper was published, okay, so in a couple of months ago, and you can see that, okay, it is coming from AHA. It's not really consensus, but it's a really the practice guidelines, and very beautiful, and anybody interested can really go through all the common endocrine problems. Of course, it is a free access. Most of you can really get this one. So with this, let's, okay, what I want to do in the next couple of minutes is to, okay, review and, okay, so revisit what we have been doing and, okay, what test we can really do in our country and what is the best approach to diagnose or probably to confirm hypothyroidism in an Indian scenario. So for that, I need to really give a bit of, okay, the physiology because to understand the diagnosis and, okay, the why we do some test and why we don't do the some test. So this is an example to show that, okay, how the T3, T4 is synthesized. So it is a start from, okay, the blood, okay, where iodine and, okay, the sodium, 2 molecules of sodium and 1 molecule of iodine, it goes to the, okay, the basal cell membrane into the, okay, the cell inside the, okay, the thyroid. And so where it undergoes, okay, at the help of a pendrin, it gets into the colloid, undergoes the oxidation, then iodination, conjugation, and, okay, with the help of a TSH, it gets back into home, into the cell, where it is really, and undergoes the proteolysis. And, okay, so then it gives rise to formation of a T3, T4. So basically, it is the iodine, and the iodine has to mix with the thyroglobulin. So where does the thyroglobulin come from? It comes from the endoplasmic reticulum inside the cell. It produces the thyroglobulin, and again, it is thrown out of the home. And this thyroglobulin, it gets mixed with the iodine inside, and then forms T3, T4, with the 1 molecule, 2 molecule, 3, and 4. So this is how, in a very simpler manner, in the layman's language, how the thyroxine takes place. Almost all the thyroglobulin is synthesized from the thyroid gland itself, the colloid itself. So it basically contains a tyrosine. So sometimes people ask why dog develop the antibodies to thyroglobulin, because sometimes thyroglobulin, it can act as a hapten. So that's why it's not surprising that some of dogs can have, both LT dogs as well as hypothyroid dogs can have antibodies to the thyroglobulins. Obviously, because the T3, T4 is bound to thyroglobulin, you can also have antibodies to T3 and T4 as well. So what happens? Once it gets into the blood, it's spilled into the blood. So what is that hormones? Basically, almost all the T4 that appear in the blood comes from the thyroid gland, whereas only about 20 to 40%. Some book says 40, some book says 20%. Only 20 to 40% of T3, only produced from the thyroid. So what happens to the remaining T3, that is 80% of the T3, etc., they all come from the breakdown of T4 into T3 in the extrathyroidal tissue outside the thyroid. That means T3, almost all the T3 come from the outside the thyroid. So which is important for us? For a dog, to control the metabolism, to do all the function, T3 is the most biologically active than the T4. It is the T3 which is biologically active. It is the one which is 3 to 4 times more potent than the T4. And what happens is that once it's all get into that, in the blood, 99% of this T3, T4 bound to proteins. Very important. That means only 1% is free. So that 1% free is the one which can exert the action on all the tissues. You can imagine how powerful this T3 is. So what is also you have to remember is that T4, what we measure is the total T4, it's a protein bond. So why I'm telling this here is that we are using a human laboratory. So the protein binding in the human is so different to the protein binding in the dog. So when you send a sample to the human lab, obviously you'll have a different numbers, which I'm going to talk a little later. So that keep it in mind. So it also depends on the amount of binding of a protein, also obviously amount of the protein in the blood as well. So all this can influence the T3, T4 level there. So that is something that you have to remember. So these are the enzymes which are important in controlling the T3, T4 level. I do not expect you to remember all the things. What I want you to remember is there are some tissues where the oxygenation, the metabolic rate, etc., work without this enzyme. For example, in the CNS, in the uterus, or in the ovaries, and also in the case of the hypophysis. So these are the places where they don't need this kind of enzymes all the time. They can work without this one. Is very, very important. So otherwise, do not worry too much about these enzymes. So put it in a one short. What is the function of thyroid? It has an effect on every organ in the body from top to the bottom. So the most important is the metabolic rate and the oxygen carrying, oxidation of the fat, particularly cholesterol, important in the erythropoiesis, and it is important in the protein catabolism, important for the growth, important for the skeletal, important for the nerve tissue development, and so on. So the functions are so much varied. Obviously, it's all reflected what can happen when there is excess of these hormones or the deficiency of this hormone. So that's very, very important to remember all this for your interesting. Now comes hypothyroidism. Why do the dogs develop the hypothyroidism? So we all know that as per the literature, 95% cases come from so-called our famous word immune mediated. In the cats and dogs, if you are lost, we say idiopathic immune mediated. So go for a steroid. So most cases they believe to be because of a lymphocytic thyroiditis, 95%, and possibly the idiopathic atrophy. The remaining, the secondary and the tertiary are quite rare. Congenital is possible, is been reported as well. So if you see the lymphocytic thyroiditis, yes, it has been reported in certain breeds, it is heritable. Is it a disorder of immunoregulation? Is all question mark, and nobody knows that. And in this case, about 50% of hypothyroid dogs can have antibodies to the thyroglobulin. Okay, so I'll come to that, why it is so important. What it means is that if the dog has a antibodies to the thyroglobulin, does not mean that is an hypothyroid dog. So that's very important because not all the dogs can develop hypothyroidism, but some dogs can develop that. So when this inflammation of so-called lymphocyte infiltration can take place, they believe that it can start as early as in the puppy age itself. So these puppies can develop this inflammation in the thyroid gland with the infiltration of lymphocytes, monocytes, and the macrophages, and it takes months and years before they can develop a signs of hypothyroidism. So some people do this so-called antibodies to thyroid to predict whether this dog can develop the thyroid or not, particularly in the breeds like Doberman. So that is something you can really have to remember that as well. So this is just to show the picture of how normal thyroid gland look like with a nice cells, whereas this is completely infiltrated with the lymphocytes, macrophages, and the monocytes. So atrophy is another cause, but some believe that it may be sequelae to the inflammation of a lymphocyte infiltration over a period of time. It can become an atrophy, or is it a different entity is still a question. So nobody is clearly aware of that one. Congenital, as said, it's possible, it's been reported, and but I have not seen, probably I don't have that competency to diagnose this, but anyway, so with this background, let's go very quickly. So what are the challenges we have in India? So the problem with hypothyroidism that there are no telltale signs. There are no specific signs which you can say that it is a hypothyroid case. So as Dr. Marcella said, atopy is always by rule out. Many times you have to consider many of these vague clinical signs, and you have to narrow down. The second challenge is that we do not have any test, the blood test, which can 100% specific, sensitive, or accurate in diagnosing a hypothyroid case. So, and also third is that non-thyroid illness and the drugs, others can also influence the thyroid results. So that is a little bit challenging. That's what we always face. So that's maybe the reason why we becomes overdiagnosed. So for me, the classical example, what I see in the Bangalore, most cases with epilepsy that come to me, they're always on the thyroid supplement. Despite we have been talking about that phenobarbital can reduce that T4, still the dogs with the phenobarbital, I find that a lot of dogs are on that because they've done the routine test, they found T4 is very low, and they started on the thyroxine supplement for an epileptic dog. Just to give an example of that. So these are the breeds, example classical breeds, and there's a big list. Probably you can see which are in the bold, which is common to our country. And these are the breeds with the congenital. I think so, I will not go very into detail. I think they're all self-explanatory. So what are the common signs of hypothyroidism reported globally? So I put it in one slide. 80% have a dermatological manifestation, whereas rest can have a symmetrical alopecia, hyperpigmentation, recurrent pyoderma, mixed edema, which I have not seen, obesity, lethargy, bradycardia, weakness, etc. And this is what some of the books talk about, how it look like, the classical bilateral, rat tail, around the area of friction, and also on the nose. So let's see some of the pictures, how they really appear like this. So these are the dogs, what they call, they look very mentally dull, totally dejected, not happy with their life, as if they lost a girlfriend or a boyfriend. And obviously, they're not ready to come for a walk. They do not really get excited seeing other dogs or even the family members. They find why my dog has become all of a suddenly dull. So these are few pictures I've seen. In case of a mixed edema, which I have not seen personally in my life, probably I not noticed, and they say when there is a mucopolysaccharide accumulate, they have a kind of a tragic face appearance. So that's what they say, but not always. But most of the time, that the dog is very lethargic, mentally dull, intolerance to cold, not ready to come for a walk, and so on. And the air coat will be rough, brittle, etc. These are the symptoms. So this is the one dog which I saw, again showing that classical alopecia on the other side. So this dog has been treated for kind of a mixed infection. They thought it is a malassezia, bacterial infection, treats, and it comes back. As Dr. Marcella said, one of the clue is that if you give an antibiotic, if the itching disappears, if the lesions disappears, that means it must be non-pruritic. Okay, so non-pruritic, that must be possibly endocrine. Okay, that's where I'll put it in that bucket, that it comes to the endocrine. So this is a classical, as you can see, that air coat is very rough, brittle, alopecia, and of course, because being a chronic, it end up with having a hyperpigmentation. And this is the dog with, again, with hyperpigmentation on either side of this case. This is a dog which I just talked to in the beginning, classical obesity. Not all the dogs with obesity have a thyroid. We have a many lean dogs. And obviously, it has all the classical signs with a rat tail and the friction area and secondary infection. So this is a dog again, which thought it is a flea bite allergy because it confined to lumbosacral. This dog has been on all the drugs which control the fleas, including the pills. And all it had is alopecia, non-pruritic, but definitely it is hyperpigmented. And this turned out to be a classical hypothyroid case. Then some of the classical case, which are taken from, are still from some of the authors, rat tail. So do consider rat tail as a part of the hypothyroid, but not all the rat tail is equal to thyroid. That's what my take home message for you here. And this is something which I learned about 5 to 6 years ago in one of the lectures, which I took it from the Dr. Harris, has put it in the win.com as well. And he has shown that this is a dog which has come only with the nasal alopecia in the nose bridge with a pigmentation and no other symptom. And this turned out to be a case of hypothyroidism. So this is something we see normally, but do not get confused with so-called hyperkeratosis in the Labradors and etc. But there is no hyperkeratosis, as simply alopecia with the pigmentation. Dog is least bothered. So this can be one manifestation of hypothyroidism in the dog. And again, cordomedial aspect of the thigh. So we think of only the fleas, but it can be hypothyroid dog as well. And this is the Jodita we just talked about. Obviously, it turned out to be classical hypothyroidism. And the last few cases where this is a Dachshund and this dog came with a superficial pyoderma, has been treated repeatedly, but they never really bothered to take the history. So this is what Dr. Marcel has been telling. We don't spend in dermatology. We need to really collect the history, how it started, how it progressed, and pruritic, non-pruritic response to treatment. Believe me, it gives a lot of clues and the right direction for the further investigation. Again, few cases of recurrent pyoderma, where it turned out to be a case of, this is a moth-eaten appearance, as you all seen that, that turned out to be a classical hypothyroidism cases. And few cases of interdigital pyoderma, not every case, which are very stubborn. We are treated everything else before considering the laser or podo for the what we do for cystic pododermatitis. It can be classical hypothyroidism as in this case. So do consider when they come repeatedly, include the thyroid profile. The other common symptoms which we read in the previously test books, because I've been talking that I believe only in the kind of a strong evidence, because this is now in the age of evidence-based practice. People do challenge you. If you really try to tell that is possible, they want a confirmation. So many times we see these cases of neurological manifestation. Some people, I had a case, they said it responded to thyroxine, the megaesophagus, peripheral neuropathies, and focal myasthenia gravis, myopathies, even corneal lipidosis, dwarfism, and even demodicosis. So is there any strong association? But I've been trying. Probably Dr. Marcel can also answer at the end if there any find a strong relation between these two or anything that is something reproducible. So the reason also I put it is on the reproduction. All the literature talks about the reproductive abnormalities in hypothyroidism is almost all experimental. But have they seen such cases in the naturally occurring hypothyroidism? Very few. But nobody has a strong evidence that it is really because of a hypothyroidism. So do consider that as well in that one. So this is the case of a corneal lipidosis, and again, is a very casual relationship. Is it really a cause of because of a hypothyroidism? So if you want to sum up, we have been talking so many, you confuse me. So can you tell me which is the most common? So we pulled out from all the literature to see what are the incidents. Unfortunately, alopecia 20 to 65%, not every dog. Dry and dull hair coat 60%, that means remaining 40% can have a healthy hair coat. Suburia 39%, hyperkeratosis 15 to 13%, pyoderma 11 to 12%, bradycardia. So some more again, aggression, cold intolerance, etc., etc. As you can see, that self-explanatory. So nothing is really specific. There is a big range of reported signs. So that makes really more confusing to diagnose hypothyroidism. You can do the ECG, but not every case of a bradycardia is a hypothyroidism. Of course, the dog is always excited on the examination table. You may not be able to get that one. So something that can really support in Indian condition is that do kind of this triglycerides and cholesterol, and most cases okay, they say 70% have a hypercholesteremia. Okay, but remember, you have many Labradors, obese dogs, we have a cholesterol triglycerides 400, 500, they absolutely look normal. Okay, so don't again consider only as a cholesterol as one of the, okay, the possible cause there. And non-regenerative anemia, not always, 20 to 32% of the cases. So with this background, okay, what are the diagnostic tests available? Total T4, that's what we do it. It's very easy, easily accessible. Most human lab do it. Now we also have a veterinary specific. It's great, but unfortunately, it is not very, very specific. It may have a high sensitivity, but sensitivity is very low in the human lab where you send. So the next time you send one sample to the nearest human lab which you have been sending and run the same sample either in the Zoetis or in the IDX, then you see the different. Okay, it's not like creatinine, so you can have a fun with that. So it may be decreased with any non-thyroid illness. It can be affected by the drugs, and okay, a decreased T4 alone is not diagnostic. What about TSH? Easy, but not easily available in our country. Of course, I used to use only the Fuji machine, okay, which is overall validated. It is quite easy, but it's a little expensive in India, but still it can do. But still, about 25% of the dogs can have a normal TSH values. But again, never use human lab for canine TSH. Okay, this may be the 100th time I've been talking about this, but still I get a lot of cases where they come out with the TSH done in the human lab. Canine TSH is different from the, the human TSH. Okay, you do get some number. Okay, never use the human. Free T4, unfortunately, not available in our country. TSH stimulation, great, but not easily. I never done in my lifetime. In addition to that, age also can affect the puppies versus adult, sex, the breed. Obviously, one breed I always think of is a Muddle hound in our state, where Muddle hounds can have typically have a lower TT4. Okay, hounds, all the hounds have a lower TT4. Obesity, yes, can have a higher, which we also approve on. Okay, so that's also you have to consider. And the drugs, have a big list of drugs. I given the one which has been consistently proven. Probably the top two which I want to mention is about steroids and the phenobarbital, because we don't use the sulfonamides. Some people do use the coprofen, but okay, so steroids you can see phenobarbital, even 1 mg per kg, okay, also can affect okay, the T4. I know a lot of us use the prednisolone on regular basis. Do consider that as a very important okay, for differential. And other factors has to be considered. There is a big list, including okay, E-thyroid 6 syndrome, etc., which I'll come to that later. So in a study, they found that okay, if you look into the non-thyroid illness, almost 80% of the dogs had a decrease in the T3, 35% of the dogs had a decrease in the total T4, about 5% had a decrease in the free T4. Even healthy dogs, which is affected by non-thyroid illness. So this is something which makes us interpretation a little difficult. In addition to that, in India, these are the challenges which I just mentioned you. We do not have a reference range because a lot of us use a human laboratory and we do not have really in that. You can imagine how much we are struggling with the CBC, and they're not designed for the canine. We are significantly misusing that. And important is that you have to consider, not consider the, okay, the influence okay, of drugs and other okay, factors on this level. That are very, very something that we have to understand. So why it is so important? That's why given a difference between a dog and man, you can see the binding of protein is only 15% of the man. Okay? And also see the, okay, the half-life of a T4, 7 days versus 10 to 16 hours. There is a good news for us in the way that even if you give thyroxine to a healthy dog, you're not really done any RM. Okay, so that's a good news because it gets eliminated very faster. But if a same, okay, the person take a healthy person, if you want to lose my body weight, if I take a thyroxine, I end up with having a toxicity. Okay, that's a big difference. So that you have to remember that, because a lot of people have been saying taking thyroxine to lose their weight. So which method is that? So I was just looking for the paper. I found a couple of papers. They compared the RIA of a man versus dog, and they also use the chemiluminescence method. This is the method which all labs in India are using, chemiluminescence method, and also in mice ELISA, and also the free T4 by the IDX, which is not there in India. So interestingly, they found that okay, the method they used in the human lab in India is not as bad as ELISA or the RIA. So that means, okay, still you can use the human lab, but remember that it is not very, very sensitive, that you have to consider that. And for the FT4, the only method is the equilibrium dialysis, or we call it as modified equilibrium dialysis method. Okay, otherwise, never, okay, test that. To my knowledge, we do not have any such thing in India. So TSHA, as I said already, I will not repeat that one. Then autoantibodies. Should I really check for the autoantibodies always? Definitely not. So it only suggests that there is an autoimmune thyroiditis, but not really predict the thyroid state. So do not go for antibodies to thyroid all the time. Don't go for it. Same way for the T3, T4. Okay, so just to summarize, okay, what is that, okay, I can use? I put it in a yellow on the right, indicate accuracy and sensitivity and the specificity. The combination of free and the TSH are the great combination, but unfortunately, we don't have that free T4 in India by equilibrium dialysis. That is the biggest limitation. So let me tell you what is that you can do. Okay, so it's great, but it's definitely not possible in India. So what does that panel, okay, they recommend? If you have a classical signs of hypothyroidism, they recommend to do TSH and the free T4. Not possible in India. No classical signs of hypothyroidism, but a low T4. But remember, low T4 alone is not enough. You have to consider the non-thyroid illness. Possibly hypothyroidism, but a normal TT4. Again, you have to do the same, but they also recommend to run free T4 and TSH, but unfortunately not available. So that means it may be great for the places where it is available, but not for India there. So this is something which don't do it. Anybody is interested, you can go to that literature and read about that. I will not take the time for that. So I put it from one of the paper, I juggled the data and put it in this way. So what I put it is the red color. That is something feasible in India. Okay? So which you say confidently, I can say it is an hypothyroid. Then what is likely? Then also have a list. Okay, the confidently euthyroid, likely euthyroid, and definitely non-thyroid, and subclinical and subclinical. So it will be there in your notes. Do not worry memorizing each of one of that. So people do ask me, what is a normal values? This is what I've taken from the different sources. So they are all given a different values here. So what we did is that about 10 years ago, so one of our students when I was at university 12 years ago, because of this conflict, we did out of curiosity, we sent the sample to the Antec lab in the USA. So she was working on the obesity. We wanted to know, does the obese dogs develop the obesity? She found only 4 out of 25 dogs had a classical signs of hypo. So these are the normal values. In a healthy dog or a controlled dog, T4 was 1.1 plus or minus 0.4. That means up to 1.5, what most laboratory refer. FT4, we don't have it here, but that's the normal value. And the TSH is approximately 0.3 and the less as a normal value for the dogs. These are basically the retrievers and the Labradors, which are in this study. Whereas obesity dogs, you can see that it is slightly higher than healthy dogs. Just to prove that obesity can increase the T4. So that's an example. So probably first of a study. So I don't have a data because somehow this girl lost the data. So the same sample what we sent to the Antec lab in the US, we sent the same sample to the human lab. So we got some funny numbers for the TSH and the FT4 from the human lab, which in no way matched with the lab from the Antec lab. So the Antec lab, which is owned by the Mars Petcare now, so they have a equilibrium dialysis method there. So just to tell you that, again, use the canine specific TSH and don't use the FT4 there. So this is my summary. So appropriate clinical signs, physical examination, routine blood test, no systemic illness, serum concentration less than 0.5, or if you're using in animals less than 6, this we don't do, and ITSH, definitely it matches, and when you start the treatment, making sure that thyroxine level come back to normal. So possibly this is one slide. This is a recommendation for our country at the moment. One can challenge it, probably we can discuss this. So some frequently asked question, dog look like hypothyroidism, but the T4 is higher than normal. So possibly you have to do the further test to confirm it. So definitely you have the answer there. The pet is receiving T4, but still the T4 is low. I get this lot of question. These are possible answer for that. Okay. When to consider testing for antibodies, I said not only done, but 43%, 20 to 40% have a antibodies, okay, the thyroid dog. So if it is there, if you find T4 and free T4 are normal, ignore it. Okay, that's the take-home message. If the dog is on medication that can lower the T4, like steroid, phenobarbital, how long I should read? We don't have a specific answer, but most dermatologists recommend 6 to 8 weeks. TS was low, but the patient is apparently healthy. So don't look for T4 alone without classical signs of hypothyroidism. The dog is sick, T4 is low, better postpone, wait for a couple of months. So the last thing is, what is the right dose? Okay, we always wonder about dosage. So this is what most people use, 20 microgram per kg as a route, or in milligram, this is the what dose, or in the body surface area, 0.5 mg per kg. So if I do the body versus surface area versus body weight, like how we do for the chemo, a 30 kg dog would receive 500 instead of 660. A 40 kg dog would receive 600 instead of 880. So which is the right dose? Okay, I don't know the answer. Probably Dr. Marcella can answer, but most believe body surface area may be good, okay, for assessing. The next question comes, people ask, should I give once a day or twice a day? Okay, so we don't have specific answer, but one of the study found that it's as good as giving once a day. In North America, they give twice a day, but in the Europe, they give once a day. Okay, so it does not make a difference. Then, okay, so what is the, how do I assess the response? So most of the signs like a mental, like a dullness, etc., generally within few days, the dog becomes quite active, playful, but okay, other symptoms may take little longer. Cutaneous signs 6 to 8 weeks, and check the levothyroxine level. Normally what we do is before giving a pill and 4 to 6 hours of the pill. Some people say 2 hours, 4 hours, but a good guidelines would be after 6 hours, check the sample. And so before giving a pill, it should be in the normal range, which the dog is on the thyroxine. Then the post pill, it should be in the upper reference range, or it should be little higher. Okay, so that means you are in the right direction. So that is a clue for you there. Okay, so when should I do the therapeutic trials? I don't have any blood test. So these are some of the guidelines. Okay, but anyway, you can't do this one. Obviously, you go for straight away based on the symptoms. Luckily, dogs don't develop any thyroid toxicity. But remember, lot of even healthy dogs, you do find some improvement, particularly the air cord. So I've seen many dogs, because the air cord became good, the dog became little active, then they said, okay, this dog must be thyroid dog. That's why the dog showing started showing the improvement, but not all the time. So that means if I give an L-troxine to a healthy dog, did I really cause harm? Because I need to explain to the owner all the time when I do the trial therapy. So interestingly, dogs receiving 3 to 6 times the recommended dose for 4 weeks that do not develop the toxicosis. Still remember, okay, one of the puppy, which almost swallowed about 50 to 60 tablets, because it comes in a tiny bottle, and the puppy, Labrador 10 kg, it almost swallowed 50 tablets of thyroxine, and I asked them to keep an eye on that, but the puppy was absolutely normal. Nothing happened, okay, even after eating 50 tablets of 100 microgram tablets. Okay, so that's also, otherwise these are some of the symptoms have been reported in that one. So be cautious in a dog with the other endocrine problems, kidney problem, liver problems, and heart problems. Okay, always start with a low dosage. All right, so monitoring, which I already spoke about it. So just want to end with the last 2 slides exactly on time. Okay, so before 5 weeks, 21 weeks, what a dramatic improvement in the rat tail. And probably this is the one case which Dr. Nanjundappa referred to me, and then he followed it up. So this is before. Okay, you can see that alopecia treated as a Demodex because it's a 1-year-old dog, and it looking very dull. Otherwise, it had alopecia everywhere, and owner was so frustrated. And the same dog after about 2 months. So owner is extremely happy, and we are happy. So obviously, that is a classical thyroid case. I think this is my last slide, and thank you so much for your patient hearing. You have been always a wonderful audience. Thank you so much. So I have 2 minutes, okay, so in my allotted time. Any questions? Otherwise, over to that. Okay, I know it's a very long day for you, and so keep an eye on your bladder, and okay, I know your mind is becoming full. Yes, please. Sorry? Okay, a very good question. Okay, so it's just like asking the question, okay, atopy, how long should I treat the atopy dog? How long you should treat the atopy? How long you treat the atopy? Now, what is your answer? So you heard about atopy. How long you treat the atopy? Okay. Right.
Thank you so much, sir. No more questions? I just request, yeah, there's one question in the back. Artsy, hand over the mic. So we're just creating some space there. So I just want your 2 minutes. We will create some space in the back.
This
Two
won't
clusters
suit.
can be removed.
This won't suit. So I'll give it to her.
You can leave it there.
Just
You
2
want
minutes.
this light? Want this light?
Just 2 minutes. Somebody was eager to ask a question here. Yeah. Can come here.
Thank you. And my phone this one before I forget.
There's a mic. Mic.
Okay, you can shout.
Hi.
Okay, so I can hear you.
Hi, sir. Sir, how different is hypothyroidism in cats compared to
Honestly,
dogs?
okay, probably Dr. Marcella may be right answer. Honestly, I not seen one case of hypothyroidism and also the hyperthyroidism in cats. Clinically, I not seen. We say hyperthyroid is a hyper, but I not seen in India. If anyone has seen a hyperthyroid, unless it's an imported cat, just let me know. And likewise, I have not seen hyperthyroid in my practice. I have only textbook information. Probably I'll give it to Dr. Marcella to answer.
So yes, I agree. So spontaneous hypothyroidism in cats is excruciatingly rare. If you have those results, it's typically like drug-induced, or like CQ thyroid. Hyperthyroidism we see quite a bit in older cats, and so they present with skin-wise, they present with scaling, and of course they have the weight loss and all the other signs, but dermatologically they tend to have alopecia and scaling. So.
Thank you, Dr. Marcella.
Video comes to the Basava video.
Thyroid cytology? No, it is from the textbook. I have not done any cytology. That's the histopathology of. Yeah. So definitely, I'm not done biopsy to honestly. I never.
So if you were to do a skin biopsy, then there are some changes that are suggestive of endocrine disease, right? So you have all the hair follicles, they are in telogen, catagen phase, and then to differentiate hypothyroidism versus Cushing, the Cushing dog, let's say you have endocrine changes and you want to try to get a clue whether it's Cushing versus hypothyroidism, right? So the hypothyroid dog may have some mucinosis, and typically the sebaceous glands are normal, but the Cushing dog tends to have atrophy of the sebaceous glands and atrophy of the epidermis. In dogs may also have some calcinosis cutis, so that you can kind of like get a clue on how to discriminate between the two, right? But obviously skin biopsy is not really a diagnostic test for endocrine disease, but the things that you would be seeing that are suggestive of endocrine would be follicular keratosis, so the hair follicle is dilated, and you will have a shift of the hair follicle stage in telogen and catagen.
Thank you. That's really great information. Thank you. Any more questions? Okay.
We want to see Dr. Swali first. Yes, let me. Yeah, I'm just connecting, sir. Volume.
Hi friends, I am Dr. H.S. from Mumbai. I am the treasurer of PPM and I invite you all my veterinary friends from all over the world to attend the 11th Pasawa which is going to be held in Mumbai on 27, 28 and 29 October 2023 at the Westin Pavilion. This is one of the best platforms for veterinary education to be held and the first of its kind to be held in Mumbai, India. So I request all my friends to be a part of this magnanimous event and help yourself to enhance the knowledge over the past of 3 days and be a part of the exciting journey for education. And as you all know, Mumbai is known for its hospitality and its culture. So also be a part of the Mumbai Nagari and I hope to see you all soon.
Okay, so I'll hand it over to the third speaker of the evening, Dr. B. Nagarajan. No introductions is required. He will speak on parasitic skin diseases in cats. आया था अभी आया था कन्वर्टर one निमिषம் sir no nothing has changed just make it open अभी आया था गया वहाँ से देखो ना तुम्हारा हाँ
So good evening to everyone. I'm very happy to see you all here after a long time. I thank Sawa for bringing me here to discuss with you about the parasitic skin disease in cats. See, all of you accept that we are having more and more number of cats nowadays in our clinic. So it is very, very important to understand what is going on in the cat. So here the feline patients are having more number of dermatological issues that also you accept. So here we'll be seeing what are all the common dermatological problems what we are facing in India. See, when you list out that, first and foremost thing is parasite, then we have fungus, that is microsporum, most commonly we have in our practice. Then the third one is allergy. So the allergy, we have got combination of many things in cat, so it is a quite different chapter, we will discuss later in future. So in the skin disease in cat, see mostly clue with reaction pattern. See, it is not like dog, say where you are getting lesion as an important thing. That is distribution of lesion is very important there. Where here the reaction pattern is so important. but it is not it is not pathognomonic for any disease. It is associated with many causes. So that is very important to understand. So it is not having a single cause, and it has got several causes in that. Then it is never pathognomonic. That is one you have to understand. So the distribution pattern, the localization of the skin changes are so important. Say for example, eosinophilic granuloma, or head and neck excoriation, or the self-induced alopecia. See, all these things are very important changes which are observed in the cat. So even the miliary dermatitis. So you can see in many cases in the same pattern. So we have to identify what is the actual thing, and the distribution of that is so important in cat. See, here it is difficult because it is very difficult because of grooming nature of the cat. So it is going on licking the body. So that is also makes some confusion in our diagnosis. Then response to treatment trial may support the diagnosis. Here the allergies have not yet been well defined. So you will be having some confusion in identifying it. See, it is not as site-specific as in dogs. Say for example, abdominal licking. This is a symptom what you are commonly seen in dogs. That can be because of flea allergy or food allergy or even atopic dermatitis or psychogenic. So it is very important, as Dr. Marcella was telling about the psychogenic, it is very less percentage, but we have to rule out, before confirming it, we have to rule out whether it has got other causes. So here, these are all the important other causes we have to rule out. So that is very, very important. Then linear granuloma, that is also one another important symptom what you are seeing in any food allergy or hereditary or idiopathic causes. So it is very, very important to rule out that. Then scratching the neck, which is always seen in flea allergy and food allergy. See, these two are very common conditions in which you have this scratching of the neck. See, apart from that, head and neck changes, what you have is in the hypersensitivity disorders. It may be a flea allergy or food allergy or environmental allergy. And viral dermatosis, whatever viral dermatosis you have. See, we have got a large number of calcivirus and also the panleukopenia. In those cases, you can see this type of head and neck reactions. See, apart from that, ectoparasites are very important reasons to have this head and neck reaction, skin changes. That is Demodex, Artoductis cyanotis, and Notoderus. These things are very important parasites which are having this kind of head and neck changes. And skin tumors, that also very important, like squamous cell carcinoma, you can expect to have this kind of head and neck changes. See, whenever there is a head and neck skin changes you are seeing in a cat, it is very, very important to rule out ectoparasite. That is the first thing you have to do. Then we can see some changes in face and feet. See, as doctor was showing the photo of a nail with the pustular crust. See, the crust with the purulent discharge, which will be seen in the that nail fold. That is in the fold of the nail, you can see the crust which is accumulating in the pemphigus. So that is a classical sign in cat. So likewise, you can have the problem in the foot, like here. We have face and foot lesions in the dermatomycosis, microsporum also. So that is very important. So we have to identify the difference. Head and feet means we have to consider that first. These two things, autoimmune diseases like lupus and pemphigus, and also the microsporum and the trichophyton. So microsporums are very commonly seen in India, what we have observed. And the primary lesions, see here the primary lesions are not so obvious in case of cat. See, except some cases like pustules, what Dr. Marshalla was telling about the papules in the margin of the ear, which is commonly seen in Notoderus, feline scabies. Likewise, you can see in pemphigus. So these things are very important to understand. See, here the presentation itself will be more of secondary lesions, like alopecia, crust, excoriation, and erosions. See, the consequences of pruritus will happen to these kind of symptoms. So what are all the skin parasites we are having in India? So these are all the commonest skin parasites what we have in India. Ear mite, in that Orthodactys cyanatus is the most common, and fleas, Tenisophilus felis, fur mite, Linksucker or Radowski, that is very commonly seen in most of the Persian cats. See, even in case of ear mite, we have got more number of Persians are involved. Likewise, fleas, which are domestic short hair only predominantly seen with the fleas, not Persian. So like that we have got certain variations. And that too, the ear mite is seen in young kittens. That is very commonly seen. Likewise, feline lice. The feline lice, the Felicola substrata is the only lice we can see in the cat. That is a chewing lice. So you can see the difference between the chewing lice and sucking lice. Here the chewing lice is so common. And the feline scabies, notoderus. Of course, we do have Sarcoptes scabies in case of feline, but that is rare. Only in case of immunosuppressants you will be having that, and that is very rare whenever there is a contact with the other dog, and there is possibility. Then ticks, Rhipicephalus sanguinus and Autobius magni. These two are reported in India, but they are very rare in cat. So this is what the study what we have gone through in Madras Veterinary College. Through my student, he has done PhD in cat skin disease. See, we have done a study to identify what are all the possibility of getting fungal disease and parasitic diseases. In that we have identified some 303 cases in 1 year, 10 months duration. We have identified predominantly with the parasitic dermatosis. There is 208 cases we have seen. In that, ear mite infestation was the predominant one. Then flea infestation, then fur mite infestation, then lice infestation, feline scabies and tick infestations are very less number. So these are all the things what we have seen in our practice, in our clinic. See the notoderus, see the face, head, and all the extremities, even the tail got involved, and Orthodactic cyanatus with the sarcoptic mange we have seen in certain cases. And this is the lice, Felicola substrata, fur mite. Like that, tick infestation. See, as I told you, Rhipicephalus and Autobius magni are the two ticks we can see in cat. The Rhipicephalus is the one as you are seeing in dog. Here also it can develop into, it can transmit anaplasma and Ehrlichia. In cat, there is possibility is there. So you can see these ticks in the head, ears, neck, and also in the leg and feet areas. Whereas other Autobius magni, it will be seen only in the ear canal. So it will be having severe inflammation in the ear. So animal will be keep on shaking or scratching the ear. So from that we can easily identify whether it has got tick or not. So if you are going to examine it, we can very well observe the tick, and you have to take out the tick and see under microscope what is the actual thing. So you have to treat accordingly. So here the selamectin was found to be very useful. Whatever the tick, it is very much useful in treating the case. See, apart from that, the selamectin and serralanir, the combination is working out 100%. That is what the report says. We don't have this drug till, so we may have it in future. Then coming to the scabies. So as I told you, there are two types of scabies in cat. One is notoderus, another one is scabies. That is Sarcoptes scabies, which is very rare. But here the variable pruritus will be there. See, it can be cohabitant with the dog, or it may not be having the dog in the house, but it can have it. So the erythema scaling, thick crust and alopecia you can see in the dog, in the cat. Then you have to identify whether it is actually Sarcoptes or notoderus. How to do that? You have to check under microscope for location of the anus. So here the terminal location will be there in case of Sarcoptes, whereas in case of notoderus, it is dorsally located. What you are going to do by seeing that? So we can have a guess or telling the prognosis, or you can see the severity. See here, the underlying immunosuppression is the very important factor in case of Sarcoptics. So once you are going to see the Sarcoptes means you have to check for other underlying causes. So you have to treat that first. Then you have to treat along with that you have to treat the scabies. So the fluoral error was effective in all the cases. That is what the report says. Like that, we have got notoderus. This is a pruritic disease. It will be having a very severe pruritic and also contagious, and it will be having severity. It will be lying over the epidermis. So here you can see the battle scarred appearance. See, the battle scarred tomcat appearance is there in case of notoderus. So here also we had a case. Here also you can see the battle scarred tomcat appearance, extremely pruritic, and lesions begins in the medial side. So as you are seeing in scabies, here also the margin, canine scabies, what you are seeing, same way here also the margin will be having crust and also the papular eruption. See here the margin will be having the crust. So the medial side of the pinnal edge, which will rapidly spread to the face, and also the eyelids, neck, and become more generalized if it is not getting treated properly. So it is very important to recognize that by taking a skin scraping in these cases. So the report says that recently they have done work on this. Even along with that, lungworm also identified in a cat, Allurostrongylosis. So along with the notoderus mange, it was commonly reported in some country. So they have treated with the selamectin, and it was working wonderfully. 6% selamectin spot on, once in 3 times or 4 times, once in 2 weeks, like that they have given, and it was showing very good improvement. So the scabies, what is the treatment? We had to go for lime sulfur. It is available in the market. We have got that is 2% lime sulfur dip, that is demoscanil. What is available with the GIPs we have got, and very, very great success we are seeing in large number of cats. Like that, selamectin spot on at the 30-day interval for 3 applications are also very well appreciated, the improvement. And the fipronil spot on spray and fluorolenor, which is not available in India now. So here we had a case of 6 months crossbred female cat with the head and neck lesions, that is skin changes, which has got the self-induced alopecia and excoriation in the body. So it also had a lot of nits in the fur. So what could be the reason for this? Any clue? Yeah, by doing coat brushing, we are in a position to see the lice, that is Felicola substrata. So you can see the difference. See here the neck and head has to be assessed whether it is a sucking lice or a biting lice. Of course, we have got chewing lice only in cat available in India. So we have got differences. The head will be very aerodynamic in case of sucking lice. So it will be very narrow, whereas here it will be broader than the neck. So that is the difference. You can very well see the lice is chewing the hair. So that is very commonly seen in cat in our area. We can see that. So this is the one. The pediculosis has to be treated with the spot on. You can very well go for spot on shampoo, sprays, powders like that. In that fipronil, imidacloprid, selamectin are very effective for treating that. All household cat also should be treated, like scabies. We have to treat the household cats also. Then you have to decontaminate the bedding and other areas, grooming supplies. Then comes Demodex. See the Demodex here, we have got 2 different type of Demodex. One is Demodex gatti and another one is Demodex catti. So here the Demodex gatti is the one which is short and stumpy. We have got head and neck severe wounds there. You can see that, which is a raw wound or visible in the skin, head and neck. And also the truncal alopecia, which is so predominant in this infestation. So as Dr. Marstella was telling, you should not just leave considering it as a psychogenic alopecia. You have to take a skin scraping and check. It is very important to rule out in all cases of alopecia for Demodex gatti. See, the Demodex cati is a contagious pruritic lesion which is going to be a superficial epidermal layer, it will be seen, and it is easily contagious to the other cats. So it is very important to treat the other cats in the house with the medicine. See, in the recent report, they have identified there are 2 other species of cat, Demodex, that is, we have got Demodex murilegi and Demodex obliquus. So in the Demodex murilegi, you will be having the lesions in the lip and face, whereas in case of obliquus, you will be having the extremities. So like that, we have got differences. It will be focal in nature, and that can be treated as the same way what you are treating the other Demodex. Whereas the Demodex cati, here it is very important to understand that it is also a immunosuppressive lesions in cats will lead to this kind of appreciation of these parasites in the skin. So underlying disease suppression of the immune system has to be identified. So you have to determine whether it has got any viral diseases, or it has got a thyroid or diabetic or lymphoma or any other neoplastic reasons which is going for immunosuppressions. Because of that, it has got development of this reproduction of this Demodex cati. So here we have to control the immunosuppression by way of attending the problem, and also you have to treat the case with the fluorolanar at the dose rate of 20 mg per kg body weight. So they have tried with the various Demodex has been tried in the olden days. They have tried with the lime sulfur, ivermectin, and also the dips. So lime sulfur dip, ivermectin, and amitraz. So in these cases, it was found to be very useful. But nowadays we are not using ivermectin because of the toxicity. And the recent reports, that is clinical consensus guidelines given by the World Association of Veterinary Dermatology, they are given skin scraping is the gold standard for Demodex. Any Demodex, whether it's a dog or cat, skin scraping is very important. And Demodex in cat can be treated weekly with the lime sulfur dip, that is still wonderfully having a very good effect, 2%, and amitraz 0.0125%. So that is very, it is mostly we won't do that because it will go for licking and it will have a lot of problem, even the owner may not be following properly. Whereas lime sulfur is having some problem with the staining, and it will have a rotten egg smell and other thing. But otherwise it will be very good, and it will have a dryness of the coat, so we have to go for cleanser, all those things. Then the moxirictin, imidacloprid spot-on will be very much useful. A single dose of moxirictin will be very much useful in controlling the disease. Then isoxazole groups also very much useful in treating the case. Then coming to flea allergic dermatitis, here we have got flea incidents, particularly in domestic short hair. We have reported a large number, and over the rump you can see the distribution of lesion over the rump and tail, and also the head and neck. The miliary dermatitis is so common. So this intermediate host with the tapeworm is very commonly reported in this. So it is very important to recognize and treat the case. So here the distribution pattern. See, if it is going to be more than 60% of the cases of flea will be having flea hypersensitivity or flea infestation, you can expect to have this lumbosacral area and the tail. So you can very well see that, and also the facial lesion and flea triangle area in the inguinal area you can see. In less common, that is 20 to 60% of the cases you can see in all the neck area, all the extremities you can see, and also in the ear pinna. We can have a large number of variations in the presentation, like licking and loss of hair, self-induced loss of hair, alopecia, and excoriation, and even the granuloma you can expect to have if it is going to be a chronic, and you can expect to have the papular eruptions, you can expect to have the head and neck excoriation. Like that, we have got very many presentation in the pruritus of flea allergic dermatitis. If it is going to have more of flea on the body, there is chance for getting even anemia, and it can be fatal also. So it is very important to understand that it is very reproduction is taking place mostly in 18 to 30 degrees centigrade, and also it requires high humidity is very much required, relative humidity 70 to 80%. So the most prevalent in summer, and also it cannot be survive in colder climates and also in the low humidity areas. So these are all the eggs you can see. That's why we have to treat lot of, it has taken from a fur. So when we do combing, it was having a lot of eggs on the table. So it is very, very important. See, you have to understand that each flea will be laying egg 4 to 50 egg per day, and they are going to hatch from larvae 1 to 6 days. Then adult emerge from the pupae at least 2 weeks, as little as 2 weeks. So it is very, very important to recognize the other portion, the life cycle, not only the adult. You should not consider only the adult in the animal's body. You have to understand that it will be having other life cycles, that is like egg or pupae and larvae, everything will be there in the environment. So you have to treat accordingly. We have to treat that. So the completion of life cycle typically takes 3 to 8 weeks. That is very important. Depends on the relative humidity and temperature. The moist, warm environment is ideal for the reproduction of the flea. See here, the treatment strategies means we have to take care of the flea adult, and also we have to take care of the other eggs, larvae and pupae in the environment. So you have to identify untreated pets in the environment. That is also very important. And choosing the products that address these things to control the life cycle. All life cycle has very important aspect of the treatment. So as I told you, the 50%, more than 50% of the egg will be there in the environment. So it has to be taken care by mere spraying the area, and you have to go for treating with the IGR. So that will the insect growth regulator, which will have control over this life cycle. So we have got the products with the esmethobrim or pyriproxyvan. So this esmethobrim is going to have some sort of exposure. If it is going to get exposed to the sun, it will get denatured. So you have to understand that. So what we have in India, the products which are having more of esmethobrim and fipronil, they may get affected with the sunlight. So it is very important not to get exposed to the sunlight. So if it is going to be pyriproxyvan, it won't have any action over the sunlight. That is the difference. Then we have got selamectin, that is also working wonderfully, and isoxazole. We have to yet to have those things in case of cat. So there is a case, Sarah, female, non-descriptive 1 year, which had a very severe excoriation at the tail, base of the tail. Face, dorsolumbar, erythema, all the area were having affected. So what could be the reason for this? The tail base excoriation is so severe in this case. So generally we consider that, but in this case we have checked the ear. It was showing pinnipedal reflux, and it was having otitis externa. It was having increased cerumen secretion, excoriation at the pinna, base of the ear. Sometimes we may have, some cases we had hematoma in these cases. So we had examined, it was showing otoductis sinatus. So that is the typical thing you can see. In some cases, male, female, you can see, and that will be having, in some cases, very few mites you can see. Some cases we will be having a huge crowd, like thousands of animals, mites you can see. This is the male and female, and this is the egg you can see. And here it affects mostly the kittens, and also it will be definitely having bilateral otitis externa. And you can very well see it is contagious to other animals, in contact animals. So that's why in neonatal it will be affected more. So it will be easily having contact with the other thing. The face or other dorsolumbar and the tail base areas also affected. That is very, very important. So dry, brown, crumbly exudates you can see in these cases, self-induced alopecia, and severe lesions, erosive lesions around the ear you can see. At the base of the ear, if you are going to examine, you can see the lesions, nail mark you can see. So that sometime if it is going to be very severe, it will go for even tympanic membrane rupture. Even the vestibular signs, animal will be head tilt. So you have to check like this, you can see in certain cases. See, we have got not only mild, it can be huge like this. Thousands of mites can be there inside a cat. So most commonly this number of mites in a huge crowd you can see in cat, not in dogs. So it is generally we have seen like that. So here then again evidence-based medicine suggests that selamectin, imidacloprid and moxidectin was found to be very much effective spot-ons which can be easily followed. And again there are reports stating that selamectin plus saralanor was highly effective than the imidacloprid moxidectin. That is, it is going for 94% and more. So the treatment of autoscariasis, always we can go in for moxidectin, selamectin, furularanor or saralanor. Here we have moxidectin and selamectin that can be very well used. And the furmite, so that is the commonest thing in our Persian cat. In our practice we might have seen large number of cases. See here we have seen the history, that is pruritus, hair fall and other cats involvement also very importantly we have seen as a history. So here the salt pepper appearance, that is a very important thing you can see in the fur. So when you examine from the distance, if you are going to see, you may not be appreciating the disease. If you are going to see closer, then we can very well see this salt pepper appearance. So even sometime it will be zoonotic. So you can very well see the owners also getting involved in that. So in case of clinically the dog, when you are going to see a case, you can very well appreciate the salt pepper hair, pruritus and severe hair fall, all the very important clinical signs you can see. Sometime you will be having the miliary dermatitis, erythema, scales and other as other symptoms. So here we have got very important presentation. You can see the opisthostomal plate will be having a transverse striation in case of male. You can very well appreciate that when you see under microscope. So it is not seen in female. So that is, it is a cylindrical body. You can very well appreciate by seeing the body and elongated, striated, that you can easily see the thing under microscope. So the pruritus and alopecia might be more related to the hypersensitivity reaction than the number of mites there. So because of the hypersensitivity reaction, it is having an intense itching. So these are all the fur mite what we have seen in our clinic. You can very well see the cylindrical body which is moving fast. You can very well appreciate that under microscope. So we are the one who reported first in this fur mite which is in cat in India. First report we have done on 2017 in our college with my colleague, and after that we have got very many publications. We started getting it, and now we have got a study in that we have done a tape impression. See where to find out the mite, where you are going to take a sample. That is what which is the best place to identify. That is what we have done. In that we have found out that proximal hind limb or distal hind limb and perianal region and dorsal tail head. These are all the places in which you can get you can fetch more number of mites. In case of tape impression or even the trichogram, we can get more in case of base of the tail. So the tail area is the very important area where you can get the trichogram or a tape impression, where you never miss the mite. So that is the place where you have to see. So we have done that therapeutic trial in cat mite infestation also. At the time, 2017, we didn't have selamectin. We sparingly we had this moxidectin. At the time only it was introduced. It was not available everywhere. So we had a fipronil spray, and also we had this ivermectin. So we wanted to try with the trial. So because considering the toxicity of the ivermectin at the dose rate of, because a lot of authors are saying 0.3 mg per kg body weight is the one which will be very helpful to treat the case. So we have identified the toxicity is so common, and that too in young cat it is more common. So what we wanted to know whether it is really helpful or not. Like that, we made a study in adult cat which are having the mite, and also we selected a cat which is having more than 2 kg. And also we have reduced the dose. Instead of 0.3, we have made it as 0.2 milligram per kg subcutaneously. Once a week up to 3 weeks we have done. And fipronil spray also we have done. So in that we have identified moxidectin was found to be very useful. Single spot on is quite sufficient to treat the case, whereas ivermectin required more number of injections. And considering the toxicity, and everyone is avoiding ivermectin nowadays, and it is not recognized all over the world. And even our paper has been rejected because of we have used ivermectin. So that is a very important thing. Later I came to know that. So it is very important not to use ivermectin because it is very toxic. See, we are simply using any drug without any fear. But in abroad, they have to answer. They are answerable. Even they will go to court. Nowadays, we also started having the problem. So it is very, very important to understand the toxicity and avoid the ivermectin usage in cat. So that is very, very important. So here also we have got a single dose application of moxidectin was highly effective in treating the Linksacara rhodosky. See, apart from that, recent reports in Indian authors, we have from Kerala, they have treated the cases of Linksacara with the selamectin, and it was found to be very effective. And it was not having any issue, or there is no side effect or anything. So it was very safe, and it is very useful for eradicating the fur mite. And there are reports stating that the Sarolaner 2 to 4 mg per kg body weight was very useful in treating the fur mites. So we had a case like this: severe erythema, 1-year-old male, domestic short hair, erythema, excoriation at the nose. What could be the reason? Any idea? This is mosquito bite hypersensitivity. Okay, so generally we have a mosquito bite hypersensitivity like this. Apart from that, we also have, in certain cases, we will be having the papular eruptions in the pinna. So that is also possible, and the hypersensitivity reaction we can very well understand and appreciate. So that can be easily confirmed by taking a cytology. In that area, if you are going to take a cytology, the eosinophils will be there, as we are seeing here. So there are reports stating that it is a type 1 hypersensitivity reaction. So the glucocorticoids are useful in treating the cases. Immediately they will get resolved. So the preferred sites for mite infestation, as you know, ear canal, ear mite will be very useful. And for the Tennicephalus felis, you can go for fleas, you can go for dorsum, and Demodex, face, neck, abdomen, inner side of the upper hind limb, and Notoderus cati, pinna, face, distal extremities, and formite, perineal, and tail areas. That is, these are all the areas where we have to concentrate while taking the any scraping or tape impression or anything, because the mite prefer these sites. That is very important. So we have done the efficacy of various parasitic diagnostic tests also. So in that, fur mite was very much useful to go for trichogram, coat brushing and tape impression. Through that we can very well appreciate the fur mite, and ear mite of course with the ear swab, and the lice we can have with the coat brushing and trichogram, and flea dirt can be identified with the trichogram, coat brushing and tape impression. So the scabies always with the scraping is the better way to identify. So that is the thing what we have got in our research. So the take home message is recognize, confirm and treat early and cure early. So in any cat parasitic disease, lime sulfur, selamectin, isoxazole are effective parasitic effective in the treatment of parasitic dermatosis in cats. Thank you. So we expect all of you to come over to Boston. Thank you. Before that, we also have our own Indian Congress on June. This is July. We'll be having at Goa. This is the first announcement what we are giving. So in Goa, June 7th, 8th, 9th, we have the program. That is Friday, Saturday, Sunday. Please do come. Thank you.
Thank you so much, sir. If you have any questions, yeah, Dr. Chavan, please.
Thank you, sir. Wonderful, wonderful presentation. Round of applause for Nagarajan, sir. Thank you. Sir, small questions. Maybe people might laugh at me, but I must ask. In old times or in recent times, some vets are using ivermectin drops inside the ears. Is it safe or is it ototoxic? And second question is, what is the best product to use to put ear drops inside the cat's ear if the cat has ear mites? Because we don't have a product in India, but in other countries they have imidacloprid ear drops. So we don't have that in India. So
that is the problem. We don't have many products in India. They are yet to come.
I hope Rajan sir is listening to.
Yeah, that's why he is going to produce that and give it us.
Sir, what do you think of putting the ivermectin in the ear?
Yeah, present people are following it without any toxicity. See, it is better than the injection and other things. But the concentration, what you are applying, may not be sure, no? So it may affect the thing. So it has to be, see, we have done the study itself with the owner's consent. We cannot take for all in our private practice, no? Sometimes it is going to happen. If they go to literature and see, and if they are going to go, then we are not going to.
So can we dilute the current ear drop with ivermectin, or that's not correct?
That is actually
so for dilution, what do you recommend?
Yeah. Strictly speaking, what whether it is advisable to go for ear drops or not.
So I would say probably the safest thing is pyrethrin, not permethrin, but pyrethrin, okay? And I guess I would always be concerned whether the eardrum is intact or not, right? Because if you start putting things directly in the ear canal, then you may have neurologic signs, right? So if it penetrates. And then another consideration I would say is that ear mites can temporarily leave the ear canal and go to the rest of the body. So if the treatment is primarily focused on the ears, you may have a failure. So it looks like the ears are getting better, and then mites are getting out of the ear canal on the body, and then they're returning to the ear canal, and then it looks like a relapse, you know? So if possible, I would treat them systemically.
Sir, one question here. Sir,
Doramectin is not helpful in cat. They have got report. Now, in dogs, they are very much useful. And in we don't have any idea, or we have not used it.
So I would now request Dr. Marcella to deliver her second lecture for the evening and the fourth lecture for the day. Her topic would be approach to recurrent infections and judicious use of antibiotics and antifungals. Dr. Marcella, please.
Good evening, everybody. Thank you for being here. Such a large number. I realize that you are taking time away from your weekend, so I appreciate you. It's good to see all this desire to learn. Two things. One is that you will have access to this presentation, the PowerPoint, so don't forget downloading that if you're interested. Two, you can reach me by email. My email is my last name at UFL, like Florida, .edu. So if you have questions afterwards, you can reach me that way as well. So we're going to talk about infections, and particularly how to address these recurrent infections. I'm going to talk about bacterial and yeast infections and how to handle them and common reasons for treatment failure, because this is a common problem in dermatology. So in my experience, common reason for treatment failures, the first one is the failure to identify the triggering disease, right? So we said infections are secondary. So if we don't address the underlying disease, they're going to come back for sure. Another cause for recurrence is the fact that we are not using the right drug. So we are either using the wrong antibiotic, the wrong dose, the wrong duration, and or we are constantly using steroids at the same time. So steroids are a reason for relapsing bacterial infections, and actually they encourage resistance as well. So I'm going to go over each of these situations one by one. So failure to identify underlying causes. So one thing that happens a lot is that animals come to you and they're itchy, and we feel compelled to provide symptomatic relief, which makes sense, right? But the point is that if we always give an antipruritic medication at the same time that we give the antibiotic, we will miss the opportunity to figure out if the disease is an itchy disease or not once infection is gone. So it's okay to start with a little bit of an antipruritic, but and at this point you want something fast, right? So your options are two, is either steroids or Apoquel, because the rest takes longer to work. But then at some point you need to ease out of these medications, because then you want to be able to answer the question, is this an itchy disease or not once infection is gone, okay? And so sometimes you have that information from the history if the owner is aware of how things developed over time. But many times people are not that, they're not paying that much attention. So they all come to you and say, is itchy, is miserable, and you need to work backwards. So peel that onion, remove the infections, and see what is left. And at this point, I made a list of what are the common causes for pruritic diseases, as underlying diseases, and it's basically allergy or parasites. Those are the two main categories. On the other side, for non-pruritic diseases, you have categories like the endocrine, primary diseases of characterization, and then Demodex can go either way, right? Now, one word on diseases of keratinization. Seborrhea, which is scaly, crusty skin, is a very common presentation in practice. The vast majority of seborrhea is secondary, okay? There are very few cases of primary disease of keratinization, and those start at early age. The classic history, young puppy, 2 months, 3 months, they are greasy, crusty, and at the beginning, they're not itchy. They become itchy later because they, of course, pile up bacteria and yeast, okay? Different from the dog that comes as a 3-4-year-old that is an itchy, crusty dog because he had, let's say, allergy or he got malassezia on top of that. Of course, it's greasy, crusty, and itchy, but that is a secondary disease. So statistically speaking, the vast majority of seborrhea is secondary, and so you will have to kind of figure out the underlying disease. Now, let's talk about duration of treatment. Vast majority of dogs, if you pick the right antibiotic, they're going to start looking much better in 2 weeks. That does not mean that the infection is gone. So if you were to discontinue the antibiotic at that time, you are going to most likely have a relapse of an infection. So as a general rule, a superficial pyoderma, let's say folliculitis, requires 3 to 4 weeks of treatment if you go with systemic antibiotic. And the rule of thumb is 7 to 10 days past resolution of lesions. Why did I add this? Is that some dogs may require, let's say they've been on a ton of steroids before they saw you. That kind of case is going to take longer to really clear. Because he has been on so much steroids, all that inflammation is gone. So it may look like it's clear, but if you were to do cytology, you'll find out that they're not completely clear. The hypothyroid dog is going to take a longer time to clear from the infection. So the rule is 7 to 10 days. By the time they look beautiful, 7 to 10 days more of antibiotic. For the deep pyoderma, so the furunculosis case, is typically 2 months or 1 month past resolution of the clinical signs. So if it takes 2 months to clear, 1 more month makes it 3 months. So it's a long course. Now, how do I know if I have a case that comes to me and it basically has this chronic history on and off antibiotic? My general suggestion to you is this. If the scenario is that in less than 2 weeks the infection comes back, it means that you're dealing with the same infection that never went away. It looked like it did, but it was not. So it's the same infection, so it's not a true recurrence. If on the opposite, you have an animal that comes back with an infection in a month or 2 months or 3 months, that is a true recurrence, which means that the issue is the fact that the underlying disease is not being addressed. It's not because you did not go long enough. So less than 2 weeks is the same infection. Longer than that is a new episode. Same is for otitis. If you have patients that come back with a new bout, quote, new bout of otitis externa in less than 2 weeks, it means that you never fixed it in the first place. And many of them actually have otitis media. And it looks like externa, and what you're doing is you're putting drops, it gets better. The moment that the drops go away, the infection comes back. So because it comes from the bulla. So it's a deeper problem. So what happens, back to our skin, what happens in many of these cases is they alternate between cocci or bacteria and yeast, right? So sometimes you have to treat both of them at the same time. Now let's talk about antibiotics a little bit. So in order to be successful, we need to know what bacteria we're trying to kill, right? So statistically speaking, the vast majority of canine pyoderma is Staphylococcus. So the vast majority of them is pseudointermediates. There might be other types of Staphylococcus as well, and I'm going to go over the list, but pseudointermediates is by far the most common. So what are the things that we need to remember about pseudointermediates? It's coagulase positive, beta-lactamase positive. What does it mean? That without any mutation, drugs like amoxicillin, ampicillin, penicillin, they will never work because it's beta-lactamase positive, okay? And is equipped for dog skin. Staph aureus can be also a cause of pyoderma in dogs, but Staph aureus is the type of staph that goes on human skin, goes on horses, and it may go on cats. Okay. Why is this relevant? That if a Staph aureus becomes methicillin resistant, it means that the potential of transferring the carrier stage to the owner is high. And at that point, aureus is well equipped to stick around on human skin. even after the pyoderma of the dog is resolved. Other types of Staphylococcus that you can have on pyoderma is Schleiferi. So Schleiferi is typically what we find in animals or people that have been on antibiotics on and off. So in humans, it's typically people that have been in the hospital and they have been sick on and off and have had multiple courses of antibiotics. And the same is in dogs. Okay, so Schleiferi typically by definition is multi-drug resistant. And so we need to be aware of it. And then there are coagulase negative that historically they've been considered benign, but now we know that it's not always the case. So it's not always the coagulase positive that are an issue. Sometimes coagulase negative can be a problem as well. Okay, so now let's move to methicillin resistance. So methicillin resistance is an additional mutation that happens in Staphylococcus. And when that occurs, it means that all beta-lactamase drugs are out. So it means that it's not an issue of switching from first-generation cephalosporin to third generation. They're all out. Amoxicillin, clavulanic acid, out. And unless you're using fifth-generation cephalosporins, which I strongly discourage you to do because it's something that we want to keep for humans, all these medications are ineffective. Now, many times, these bacteria are also multi-drug resistant, not just methicillin resistant. What does it mean? They are resistant to antibiotics belonging to multiple family of drugs. So they may become resistant to clindamycin, sulfonamides, fluoroquinolones, okay? So all those become like ineffective. And the challenge with this is this resistance can be transmitted from dog to dog. These bacteria are shed in the environment, and they can be transmitted to owners. So basically the resistance, it doesn't stay just with the individual that had received the antibiotic. It's something that is transferred to other individuals. And this is why I want to spend a few minutes talking about Staphylococcus and how can contaminate the environment and the people that are in contact. So there are several studies that have addressed this problem, so I want to share some of the results with you. And also I want to make you aware of the fact that you can have multiple strains of Staphylococcus on the same dog. So this is why I encourage you, when you do a culture, to swab multiple areas on the body. So again, you can have 4 different strains, and what it becomes evident is when you start treatment that you may be killing the most vulnerable one, and you're actually selecting for the most pathogenic. So do a swab in multiple areas so that when you submit to the lab, you have multiple strains of Staphylococcus. Now, let's talk about how this resistance can become a problem for owners and the environment, okay? So it becomes a potential for zoonosis, right? Because if the Staphylococcus, in this case, pseudointermediates, can temporarily go to owners, then it means that they are acquiring this ability to be multi-drug resistant or methicillin resistant. And this becomes an issue, particularly if at that point they're going to have surgery. Let's say they need a new hip, a new knee or something, or they are undergoing chemo, in which case they become immunocompromised. So when they do develop an infection, then they're going to develop an infection with the Staphylococcus that is present on their skin. Okay? And so they basically, there are studies to show that people that own dogs with pyoderma that have been on antibiotic, they are more likely to carry this multi-drug resistant staph. Okay? Most of the time, if the infection is clear, this carriage stage on the owner goes away. okay? But it may take a long amount of time. I'm going to share the results of a study that demonstrated how long that can persist in the environment. This is in the event that you just have pseudo-intermediates, because like I said, if you have aureus, your carrier stage may be forever unless the owner goes to the physician and basically does treatment to eliminate the carrier stage. So one study that looked at the permanence of Staphylococcus in the environment specifically looked at houses where they had dogs with pyoderma in the previous year. And they had 20 different households. In 10 houses, by the time they collected the swabs, there was still a dog that was positive that still had an infection. And in that case, if they had multiple dogs in the house, the vast majority of them, so 86% of them, they were carrying the same Staphylococcus. They did not have pyoderma, but they carried the same resistance on their coat. So if you have multiple dogs living in the same environment, they were most likely than not to carry that resistant Staphylococcus. And that means that we need to start doing topical therapy on everybody in the house, not just the one that has pyoderma, because we want to avoid that the, quote, healthy one functions as a carriers, and then it gives it back to the atopic one that when he gets his pyoderma back because he has allergies, is going to have the resistant pyoderma that is going to be very difficult to treat. But the interesting fact is that even in the houses where the dogs had resolved their pyoderma, 36% of the dogs living together, these were still carrying the Staphylococcus. So the take-home message is that you have staph that is shed in the environment. And so people and the house become positive for this Staphylococcus. And we do know from humans that if you have eczema, you always walk around with a larger number of Staphylococcus in your skin. So if somebody were to swab your nightstand, your pillow, and everything that you touch, there's going to be Staphylococcus in larger amounts than a normal individual, just because the skin is not normal. So they're always over-colonized with Staphylococcus. And so this is how the skin works, okay? And so if on top of that you have multi-drug resistance, then it becomes a source for reinfection. So domestic contact, and this is true for our practices, right? So we at some point started culturing the dermatology treatment room at UF, and we found Staphylococcus, multi-drug resistant Staphylococcus, pretty much everywhere, on the keyboard, on the phone, on the doorknob, because basically all we had all day long was dogs with pyoderma coming back in and out. Okay? So that is something very, very important to remember. And I want to share this experience that at some point I had a dog, a golden retriever, of course had allergies. And 6 months, he comes down with pyoderma, 6 months old. And I'm now in the habit of culturing all the time. When I cultured that puppy, he never had an antibiotic before, but his very first pyoderma was multi-drug resistant. And I am the culprit for this, right? Because I basically, I'm sure, carry multi-drug resistant Staphylococcus going in and out from work. So even if you wash your hands, you still have it on your clothes and your shoes and so on. So the point is that you can have resistance in dogs that have never had an antibiotic before. If they have exposure to somebody, a human or a dog, that is exposed to that kind of resistance. This is why, for us, resistance has become a community issue, okay? So my hope coming here and talking to you is that if you don't have this issue yet, that hopefully you don't get to the same point where we are, because we made a lot of mistakes, and so I'm sharing the mistakes with you. So one is that we use a tremendous amount of antibiotics, okay? Everybody with any pyoderma whatsoever, even very limited, went home with an antibiotic. And we made fun of the fact that methicillin resistance is a problem in human medicine. It doesn't occur in veterinary medicine. This was 20 years ago. We were so confident about that, and we're clearly wrong, okay? So we want to be very mindful of what we use when we prescribe antibiotic, what antibiotic we prescribe, and how to treat these antibiotics in the correct way, and I explain to you what that means. For that purpose, I refer you to a few papers that have been published that have the current guidelines on how to deal with staph infections in dermatology, and I'm going to give you the highlights. But the important concepts that I want to share with you are two. One is the MIC. I'm sure you're all familiar with this because that's what we learned in school, right? And so we have been trained to go above the MIC. So the idea was like that if you go above this minimum inhibitory concentration, we're good, right? But what we did not know for the longest time is the concept of mutation prevention concentration, which depending on the antibiotic and the bacteria that you're trying to kill is typically 5 to 10 times your MIC. And the mutation prevention concentration is the lowest concentration of drug that you need to use to block the growth of the least susceptible bacteria, okay? If by chance you're above the MIC and below the MPC, you actively select for resistance. So this is, you see it? Am I blind? Okay. The point is the red, okay, is that in-between area that you don't want to be. Okay, so for some drugs that are concentration dependent, is not sufficient to just be above the MIC. You need to be above the MPC. If you are barely scraping it above the MIC, what you're effectively doing, you're selecting for resistance, which is exactly what we did. So what we did is when Baytril came out, the label for Baytril was 5 milligram per kilogram twice a day. So basically, it was recommended to be used as if Baytril were a time-dependent antibiotic. Basically, they were recommending to use it almost like a cephalexin, when in reality, the fluoroquinolones are concentration-dependent antibiotic, not time-dependent. So what we know now is that all the fluoroquinolones should be once a day at a much higher dose. And I'm going to go over this. So don't do what we did, okay? So we want to go above the MPC. This is critical. Anytime you dish out a fluoroquinolone, it's essential that you go for the high end of the dose once a day. If you use fluoroquinolones alone, at all, the best if you don't use them, okay? Because fluoroquinolones should be the very last resort if you have a culture and sensitivity that it tells you that you have no alternatives. So again, there are several good papers on this topic. This is again on the special issue dedicated to dermatology that came out in JAVMA in June. It is open access. Please download it. There is a lot of information about the various antibiotics, how to use them, the various doses, which the doses in dermatology are higher than the dose that you would use for other infectious diseases because the skin has poor blood flow. So if you think about it, you are trying to get this high concentration of drug in your epidermis, okay? So that's why derm tends to use very high doses. So when I select an antibiotic, we need to be mindful of who am I trying to kill, what are the diseases that animal has, what's the ability for the owner to comply. In other words, if I prescribe a time-dependent antibiotic, I need to make sure that I have an owner that is capable of doing it at the time that is needed. Otherwise, I'm only selecting for resistance. And so I'm going to start with the neuroantibiotic first, and only if I don't have an alternative, I go for a broad spectrum antibiotic. So this is why when we select an antibiotic for pyoderma, we start with the first choice antibiotic, and then we go down the list. So what is the first choice antibiotic? If I have to use a cephalosporin, that I would go for first generation cephalosporin, okay? The third generation cephalosporin is after I don't have an alternative, and the reason is that the spectrum of action of a third generation cephalosporin is broader, okay? So I'm gonna go over each one of these options separately. What I want to say, however, is this. As I understand that you have a lot of freedom, shall we say freedom in the use of antibiotics, okay? There are some antibiotics that should be saved for people. Linezolid, for example, is one of them, vancomycin and so on, because those are to be reserved for methicillin-resistant infections in humans. So I urge you not to use them freely, okay? So let's start with cephalexin. So cephalexin is a safer choice if you have a staphylococcus that is not methicillin resistant. It is a time dependent. This is why we give it twice a day. And the dose that we're using now is a little bit higher than what we did 20 years ago, okay? But if cephalexin doesn't work, there is absolutely zero reason for you to go for a third generation cephalosporins, because the ability of a third generation cephalosporins to kill staphylococcus is not any better than cephalexin. The main difference between the two is the spectrum of action is broader, therefore the ability to induce resistance, okay? And I don't know if you do a lot of convenia here, but cefovicin, if you do have it, I can, please learn from us. What happens in the US is the following. It's an injectable, it's convenient, it lasts 2 weeks. So what happens is that people give it, guess what? In 2 weeks it looks better. So they don't come back for recheck because life is good. But the pyoderma is not done. So another week or two, pyoderma comes back. And they come back for another injection. And so they go back and forth with this exercise a couple of times, and guess what? Eventually you get methicillin resistance. So don't do it, or if anything, if you absolutely have to do it because it's a mean cat or something, sell them 2 doses at the same time. So they're going to come back in 2 weeks to get the second dose because they paid for it, okay? So at least you're addressing that issue, okay? That's my suggestion. Next category, amoxicillin clavulanic acid, okay? Amoxicillin clavulanic acid, if you were to treat a UTI, we would use like 14 milligram per kilogram twice a day. But for skin, we go higher, right? So 22, sometimes 25 milligram per kilogram twice a day for that very reason, okay? Another option, sometimes for methicillin-resistant staph, is clindamycin, okay? So clindamycin, now we are using more and more 11 milligram per kilogram twice a day, not the original 5.5, okay? So clindamycin is a very good antibiotic if your patients are amenable to it in the sense that the culture and sensitivity supports the use, okay? Another option for methicillin-resistant staph is sulfonamides, with the understanding that sulfonamides have a lot of potential for side effects. Just to list a few is hypersensitivity. So you can have basically anything from, just a straight allergy like, type 1 hypersensitivity kind of thing, all the way to type 3. So polyarthritis, polymyositis, type 2, so anemia, thrombocytopenia, of course your KCS, your lower thyroid, and all the stuff that you know. Drug eruptions are a big thing with sulfonamides, so that's something to be aware of. And there are some breeds of dogs that should not be receiving sulfonamides, okay? Now, let's say that you are traveling toward fluoroquinolones. Okay, so my plea to you, please use them only if your culture and sensitivity tells you that you don't have alternatives. And you be aware that antacids and dairy products interfere with the absorption of the fluoroquinolone, and that all the drugs in that family are concentration dependent. So based on what I said, is once a day at the high dose. And it doesn't matter that at some point during the 24 hours you are below your MIC, because you have what is called the post-antibiotic effect. The single most important thing is that you want to exceed your MPC. Okay? Then, of course, there are situations in which are contraindicated, like young animals, right? You don't want to damage the cartilages. And then, for the situation of Betro, you do not want to give it to cats. So we did this when we did not know any better. We made a lot of cats blind, so they had retinal degeneration and so on, but we're not doing an ocular exam on these cats. So we use now pradofloxacin for cats. Okay? But if you happen to have a dog and you pick enrofloxacin, be aware of the fact that now we travel more toward the 20 milligram per kilogram once a day. Okay? Now, of course, you can have side effects at that point. The side effects to watch for at that level are neurologic side effects. So if you have a patient that has any predisposition towards seizures, fluoroquinolones are typically not a good idea. As you go toward fluoroquinolones of a newer generation, the bioavailability is better, therefore the dose is lower, right? So the more you kind of graduate to a newer fluoroquinolone, the dose is decreased. RB, the same, so the higher the availability, the lower the dose. Moxifloxacin for us is only a human fluoroquinolone, so I don't know if you have it available on the veterinary side. And pradofloxacin is what we use in cats. So that's what we have labeled in cats. Now, moving along toward like the least desirable choices, chloramphenicol. So chloramphenicol, many cultures for us are still susceptible to chloramphenicol because we don't use any people anymore, and we don't use it because the aplastic anemia. So chloramphenicol is a time-dependent antibiotic. So it needs to be given every 8 hours, which is different from 3 times a day. It needs to be every 8 hours. And it's important to explain this to the client, that it's not that you give it 8 o'clock in the morning and then you give it at 6 o'clock at night when you come back, and then at 9 o'clock before you go to bed. That's 3 times a day, but it's not every 8 hours. And so for that one, we want to be above the MIC consistently throughout the 24 hours. Side effects of chloramphenicol, of course, is metabolized by the liver. You need to be mindful of drug interactions because of the interference with P450. It can cause peripheral neuropathy. So you may have people that will comment on the fact that the dog, particularly big, heavy dogs, have a difficult time getting up. You know, they become weak and they may have changes in their gait. Typically, that occurs after 2 weeks of treatment, but the bigger the dog, the faster it is. And I tell them in advance so that at least they watch for changes so that you can stop the drug and it is reversible. But if you continue, it becomes more and more severe. Other options, rifampin, sadly. Rifampin is a cheap antibiotic for us, but has a high probability of being liver toxic. So the way we use it, we do a chemistry panel, liver panel once a week, and it's a once a day antibiotic. So it's something that we only use when we're desperate, okay? So that brings me to the next topic, which is topical therapy. So I encourage you to do as much topical therapy as you possibly can. And again, on that special issue in JAVMA, there is one review article that Dr. Santoro wrote on this topic, talking about what we know about topical therapy for infection And so I'm going to cover some of the highlights. So topical therapy is something that we do more and more now, either as monotherapy or as adjunctive therapy. You can do the shampoo, or if you have products like sprays, leave-on, conditioners, mousses, anything that has a prolonged effect that's desirable. And the advantage of topical therapy is that you can deliver a large, high concentration of something directly where you need it, which is what we have a difficult time doing with systemic treatment, right? You can provide immediate relief for the itching. You also, many of these patients are allergic, so you are physically removing the allergen just by putting them in the tub and bathing them. And you may also combine with something that has skin barrier repair function. So you have a lot of benefits. The downside is a lot of work for the owner. So it depends on the size of the dog and the commitment of the owner. But hopefully you can convince them how critical that is. So the options in terms of killing Staphylococcus are, I'm going to go down the list, okay? So we're going to start with chlorhexidine, and we're going to talk about the other antimicrobial. So chlorhexidine has the advantage of being effective against gram-positive and negative, and also for yeast. Okay, so these are all positive things. You can also use it in some cases of dermatophytes, and so this is all beneficial. The disadvantages of chlorhexidine is that some patients can be irritated with it, and some, they can actually become hypersensitive to it. So you need to monitor these cases, particularly if they do a lot of chlorhexidine, is whether the animal is getting dry or is getting itchier after the bath, because sensitivity to chlorhexidine can occur. It's not a rare situation, okay? Now, there are many products, at least for us, ranging from 2% to 4%. And there are studies to show that it depends on the vehicle of the product. There are some products that claim to have 4%, but it gets out of solution, and so you don't really have 4% in the product that you're using. So not all chlorhexidine products are created equal, let's put it this way. There are studies that have shown that twice a week chlorhexidine bath is just as effective as oral amoxicillin clavulanic acid. Okay, just as effective if you have a methicillin-sensitive staph, and is even more effective if you have a methicillin-resistant staph, because methicillin resistance does not translate into chlorhexidine resistance, and that's key. All right, so maybe that's something that can motivate owners to do this topical therapy. Another ingredient that is antimicrobial is ethyl lactate. Okay, so ethyl lactate increases the moisture of the skin, it kills bacteria, it lowers the pH, which is critical, because the scenario, particularly in allergic dogs, is the following. The skin is not normal. Many of them have filaggrin issues, or simply are walking around with a lot of staphylococcus on their skin, so their pH increases. So the higher is the pH, the more suitable it is for bacteria and yeast to replicate. So what we're trying to do is we want to bring that pH down. The same concept of vinegar and water that we knew from decades ago. So you want to keep that pH low. So ethyl lactate has the ability to do that. And there are studies to basically show that if you do ethyl lactate in conjunction, in this case, in conjunction with oral antibiotic, you heal faster than oral antibiotic alone. So now we try to do, for superficial pyoderma, we try to do topical only. Other options to kill Staphylococcus, oxychloroquine. So oxychloroquine was initially developed in human medicine for MRSA, methicillin-resistant staph. Okay, so oxychloroquine is very effective in killing staph. For us, it's an expensive product, but it's a very effective one. Other options to kill Staphylococcus, benzoyl peroxide. So benzoyl peroxide is used in human medicine. If you have acne, you know, it will basically open the hair follicles and kill bacteria. The human products have a higher percentage of benzoyl peroxide than the veterinary product, and this is how you can convince owners that it's not the same for them to get the human product. Human skin is thicker and greasier than canine skin, so they need to use a veterinary product to avoid excessive irritation. And even with that, chronic use of benzoyl peroxide can be drying. Okay, so that's something. Then you need to add a conditioner afterwards, particularly if you have an atopic dog that already has dry skin. Other options to kill staph is mupirocin. Now, mupirocin is an antibiotic, which is different from chlorhexidine, which is an antimicrobial. So it is okay for an owner to do chlorhexidine here and there, but it's not okay for an owner to use mupirocin here and there. If they're using mupirocin, they need to do a course of treatment as they would do for another antibiotic. So the advantage of mupirocin is that it penetrates the skin well and is effective for MRSA, so methicillin-resistant staph. Other options to kill bacteria, silver sulfadiazine. And the advantage of this is that it will kill Staphylococcus and Pseudomonas. So let's say one day you have Pseudomonas otitis, you can get Silvadine and dilute it 1 to 10, so it comes in a 1%, and you can make a 0.1% suspension, and you can use that in the ear canal as a substitution for your fluoroquinolones. Then I wanted to spend a few minutes talking about pododermatitis. So many times they get deep pyoderma in between their toes, particularly dogs, short-coated dogs. And so because of the anatomical situation of the toes and the short hair, the bacteria is basically inoculated strictly in the dermis. So you go from a superficial pyoderma to a deep pyoderma very quickly. And because of the furunculosis, you have free hair and keratin in the dermis. That leads to the formation of cysts. So this cysts act as a constant source of reinfection. This is why these cases are very difficult and very chronic. They typically require long courses of antibiotic. Many times it's important to decrease some of the fibrosis. I encourage you to do topical steroids with this feet to kind of, again, decrease the fibrosis. Some of them may need some laser treatment to remove the cyst. Some will benefit from soaks with Epsom salt just to help drain this cyst. Okay? So I encourage you to culture more maybe than what you have been doing. Certainly anytime that you have dogs that have received antibiotic before, and certainly anytime you have cases of a deep pyoderma, because in the case of deep pyoderma, they will be on antibiotic for an extended period of time, so you want to make sure that you have the right antibiotic. Now I'm going to move to and talk a little bit about malassezia, okay? So frequently these dogs also have malassezia infection, very pruritic. Many of them are also allergic. The ventral neck is a classic area for malassezia, and anywhere where they have folds, so any area of the body that is basically protected and is more moist is a perfect area for malassezia. Some dogs, they get malassezia in their nail bed, so they get paronychia, and they come with the complaint of biting their nails or just licking and chewing their feet incessantly. And the nail itself can become discolored, right? So you have that rusty discoloration of the nail. One characteristic of malassezia is the sharp demarcation between the area of alopecia and the area where you still have hair. Okay, so that is a classic sign. And sometimes some patients at the edge there, they have an area of erythema. So let's say the bald area is all lichenified and crusted and all that, and then you part the hair right at the border and you see that area of erythema. That's malassezia. So anytime you have these dogs with the history that steroids are failing, Apoquel is failing, the antibiotic is failing, think about malassezia. So what are the options to kill malassezia? So for a dog, the go-to is typically ketoconazole. Okay, so ketoconazole, particularly if the patient is not geriatric, should be, and it was for the longest time, an effective treatment to kill malassezia. We need to be mindful of the fact that the azoles, all of them to some degree, are suppressor or P450. So anytime that we also prescribe another drug that goes through that pathway, I need to adjust the dose. The classic example is the cyclosporin, right? We do it on purpose. We give it to save money on cyclosporin. But sometimes we're not doing this on purpose. Sometimes we're prescribing an antibiotic or an antihistamine or something else, and we need to be aware of that. Ketoconazole is, typically doesn't go well with cats, so I don't recommend it. For cats, the go-to is typically itraconazole. So itraconazole once a day, and has the same consideration as ketoconazole, the drug interaction, the liver metabolism, and all that. Itraconazole has the ability of accumulating in the skin and hair, and this is why sometimes clinicians use it doing pulse therapy. So to save money, they would give it, let's say, the first 2 weeks every day, and then they do 1 week on, 1 week off, or like 3 times a week, and so on. But there's a catch to this, and we're learning this, and I'm going to share it with you in a second. But this is why people have done it historically. Another option as an azole is fluconazole. Fluconazole is water-soluble, so does not accumulate in the skin and hair. So it means that the moment that you stop fluconazole, you have no persistent levels. So there's something to consider. But the upside is that it does not have any liver metabolism. It's excreted almost unchanged in the urine. So when people have patients with bad liver, then fluconazole is an alternative as long as the renal function is good. Now, if you don't want to use an azole, then terbinafine is an alternative. So terbinafine was developed for dermatophytes, not for yeast. And it was developed in human medicine for onychomycosis. So when you have dermatophytes in the nails, you would require, 8-12 months of treatment because of the whole length that it takes to regrow the nail. So terbinafine was an alternative because it's leaving me alone. Okay. So terbinafine accumulates in the hair and nail for extended periods of time. And so that is considered a beneficial quality of terbinafine. So terbinafine, you can give it orally, but you can also give it, it's time to go home. We have topical that have terbinafine. And I don't know if you have topical terbinafine here, but if you do, I encourage you to use it because there are case reports in the literature, and I'm going to pull the references when we get to it, that basically have shown that you can have cases where the systemic terbinafine failed, but the topical terbinafine worked because terbinafine does not have enough of a high concentration in the stratum corneum, but you can still have malassezia that responds to terbinafine if you apply it topically. So that's something to consider if you come across cases where you have prescribed an antifungal and you have treatment failure. And that is basically the next slide would have been to talk about resistance in malassezia. So for the longest time, we have talked about resistance in bacteria. But what we're learning is that malassezia is becoming resistant just like Staphylococcus. And there are now several publications that demonstrate that malassezia, particularly the resistance to malassezia, can be found also in healthy animals that have never received an antifungal. But certainly if you have dogs that have received antifungals on and off, particularly if they've done the pulse therapy that I was telling you, malassezia can become resistant to the azoles. And this resistance is cross-reactive in the sense that they become resistant to all the azoles, not just one. And obviously in the severity that the first generation azoles are the least effective. Let's say miconazole, clotrimazole. Those are the ones where you need an even higher MIC, okay? But it also applies to some of the newer ones. So I encourage you to use some of the newer azoles that you have, which I realize that you have many options in that department. So again, you're less likely to have resistance with the new azoles, but you can still have it. So there are several reports that have shown that you can have this resistance, which is cross-reactive across the spectrum of all the azoles, okay? So the take-home message on that is you can treat systemically, but if it comes back and then, quote, has not worked, I encourage you to do cytology to see why it has not worked. And if you still find yeast, then you need to become creative. Either pick a newer azole or go to terbinafine or go to terbinafine topically, or consider other options topically. What are those options topically? One is selenium disulfide. That is, for us, it's called Selsun Blue. It's a product that is used for dandruff in humans. And dandruff in humans is seborrhea of the scalp, right? So it's typically malassezia. So dandruff in humans is typically malassezia. So selenium disulfide is one. The other one is silver. So there are several studies that have shown that silver is antifungal. And there are actually some products, and I'm sure will come out on the market, in which they have a combination of silver nanoparticles and ketoconazole as a way to maximize the effect of the antifungal. So silver is another alternative to overcome the resistance. So let's see if it's done. It's not on, but doesn't matter. Okay, so take-home message: resistance to the azoles. Consider Selsun Blue. Consider silver, and be mindful of how you treat these patients. But you will not know if you have resistance unless you do your cytology. So cytology every single time. So to wrap it all up, what are the things to go home with? One is you want to always identify the underlying cause. Two, if you have a superficial bacterial infection and the owner is willing to, do topical as much as possible. Do topical to every pet in the house so that you can kind of like decrease the possibility of cross-contamination. If you have to go with a systemic treatment, start with the most benign before you go to the most aggressive. If you want to use a cephalosporin, start with first generation before you graduate to others. If you go for a fluoroquinolone, you want to go to the, yeah, so next, and then one more, and you're going to have all these references, so don't worry about it. One more. And here we are. So if you want to use a systemic antibiotic, save the fluoroquinolones for last. If you use the fluoroquinolones, you want to go to the high dose once a day to decrease the chances of having resistance. And don't do short courses of antibiotics. Certainly don't do pulse therapy with antibiotics. This is something that it was in the books like 20 years ago. You know, they said, oh, for dogs that get recurrent idiopathic pyoderma, maybe you can do a cephalexin only once a day, or 1 week on, 1 week off. I beg you, don't do it. It was a mistake, okay? This is the only way, I mean, they were gonna basically promote resistance and have 0 antibiotics left. I also encourage you, please don't use linezolid for your patients. Use other antibiotics. We want to save that for us, okay? So that's the gist of what I wanted to share with you, okay? So, if you have any questions, I don't know if I'm out of time, but no, I think we have time.
Yeah, we have time.
Okay. Yes.
Do you measure the pH on, say, dog's skin to see where you're standing at?
So we've done studies, so they're published, and we have done comparison between healthy dogs and atopic dogs and dogs with pyoderma, and the pH of atopic dogs is higher, and with pyoderma is higher, because that's what Staphylococcus does. So as a cheap alternative that you can recommend to your clients, vinegar water rinses, okay? So if you want to use as prevention, you can do 50-50. You can do foot baths, you know, for dogs that they're prone to recurrent other bacterial yeast infection. Doesn't matter, because lowering the pH is beneficial no matter what, okay? You can use for the ears, 50-50. If they don't have an active infection. If they have an active infection and they already have ulcerations, it might be too much. I never use it with alcohol. I only do water, white vinegar and water, 50-50, as a strategy to minimize recurrences of infection. Yes.
Do you advise hair clipping for effective topical application? In case of long hair dogs, if they have do you advise hair clipping?
To clip, it depends on the breed. So there are some, so definitely clipping makes it easier, you know, to monitor the lesions, use less products and so on. However, if I have a breed like a husky, then I warn them, right? Because it's like there is the catagen arrest, and then you get this post-clipping alopecia that they're going to blame you for the rest of their life. So I think they need to be aware of the fact that it comes with a risk. So it depends on the breed to answer. Yeah.
We have one.
Hello, can everyone hear me?
Yes.
Thank you. Thank you so much for the lecture. I just wanted to also understand, like you said, when the client comes to us and they do want an immediate resolution for the pruritus as well, and if we're using steroids, you do not recommend the use of antibiotics along with them because that's going to increase our resistance. If we are giving something like antihistamines, how long do you recommend that we give them the course for?
Good question. So it gives me the opportunity to clarify. If you want to do a few days of steroids, no problem. If you want to do a few days of Apoquel, no problem. But they need to then you need to pull out of the steroids. It's not that you cannot use steroids at all. You just don't want to use always steroids and antibiotics at the same time, right? So that you can kind of give them a leg up. So the first week I help you, then no more steroids, so that you can evaluate what the antibiotic is doing. So that's okay. Other options to make it comfortable could be topical steroids. I understand that you guys have Cordovans. As far as antihistamine, that's a sore topic. Okay. So based on evidence, antihistamines are not really that effective as antipruritic. Okay, so there are several studies that have demonstrated that. There is actually one that was a placebo-controlled study of cetirizine that showed that it was, quote, just as effective as your placebo, which is 30%. So you're going to have some people that are going to say helps, but the reality is that if you have an animal that is really itchy, probably antihistamine short of sedating the dog is not going to be your answer either. So if it's really itchy, other options that you have is lime sulfur. Lime sulfur is a strong antipruritic. The downside of lime sulfur is that it's dry, right? So you may have to add some, in the US we use like baby oil and we add it to the mix, so that you give some moisture back to the skin. So these are all ways that you can provide some relief from the itch without having to dish out other drugs. But there's nothing wrong with a few days of steroids. You just don't want them to be on it the whole time that they're on antibiotic. Yes.
Have you ever encountered an anaerobic bacterial infection, especially in the
Anaerobic? I haven't. Yeah.
Okay, so thank you so much. Thank you so much, ma'am. We are at the fag end of the evening today. We have got one more session, which is the panel discussion. I would request all the speakers to come over to the dais, and we will discuss a little more about specific topics. I would request Dr. Umesh to lead the discussion, please.
So thank you, Karthik. I mean, basically the panel is okay. So this is an opportunity because we have a specialist here. In dermatology, I've been always hearing some controversies, okay, something which you're not really convinced, or something, okay, which is always, okay, bothering you, some of the things, okay, so, which I never got the answer. Probably this is an opportunity to ask a question, and, okay, so, probably, okay, all the, okay, doubts, okay, whatever you have the clarification, probably can have a time now. And okay, I know that, okay, so even my bladder is very full. So
Yeah.
make sure that it, okay, make it fast.
So
Okay.
I will start up, and I will ask one question to the panelists. As a veterinary dermatologist, has there ever been a situation where you felt that I won't do this again? And what would be that? I won't do this again, ever in my life as a veterinary dermatologist. Has there been a situation? Probably in the approach of a patient, and what has been at the top of that mistake that you have ever did?
I think probably it comes down to client communication, if anything. If I have to think about the biggest lessons that I've learned, maybe not to deliver a clear enough message about expectations, where I either overestimated the success of something because I was confident that was going to work, and it turned out not to be the case. I have had one case on rifampin that died of liver failure despite the monitoring. So having said that, sadly I still have to prescribe it, but I'm very leery of it. Live and learn. I think if there's one thing that I can certainly say I've learned over the years, the more you go on, the more you realize how little you know. And so you become more and more humble, right? Because you've seen it in so many ways that when I first started, I was more like, oh, it looks like this. Now I'm like, it could be this, most likely this, but it might be different. I would have to think more about this question.
What about Dr. KG?
Probably, I think, as I said, okay, one thing I learned is client communication.
Right.
Making sure that a realistic expectation before they leave the consult room. That's the one. Second thing I learned in the last 5 years is, okay, not only with my fellow vets, send me a picture of a dog and a skin and tell me the treatment, which I'll never do. Because it's always inviting trouble, because you can't diagnose just by picture and a couple of history. So it has stopped, okay, answering to those kind of a thing. And the third one, as I said, okay, one is okay, communication. So I try to make sure that I'll be in the shoes of the client to understand the concern. Okay, so because I know the clients don't care about how much you know, they want to know how much you care. So that's very important for me.
Right.
Yeah. As all said, the history is so important. So along with that, the communication with the owner is so important. See, they will tell something, we will interpret something, and we have to ask more and more. Then only we can get the information from them, so that we can correct everything, starting from foodology, from atopy, everything is like that. And apart from that, we may fail to go for identifying the internal issues sometime. So if it is, say for example, if you are going for a drug which is antifungal, we have to check whether it has got any liver issue before, or borderline, or anything is there already. Those things has to be done. And whether they have done, see sometime at the time of presentation, we may not know whether they have given before long-term steroid which induced hepatopathy, and that causes this problem. Like that, we may not have a clear idea. So it is very, very important to pick up everything from the history, and then assess the patient thoroughly, then you go for further step. In between, if you start doing anything, then it will end up in mess. That is the thing. See, the hepatopathy, hepatocutaneous syndrome, all happen like that. See, it will be there for some time with a chronic disease, and they will be keep on pumping the steroid, and they will go for not only Cushing, it may even go for hepatopathy, and it induces a lot of metabolic changes. So what will happen? Finally, it will go for hepatocutaneous syndrome. Finally, if you start treating it, animal will die. Finally, they will blame you only, not the previous thing what they have done. So that is why it is very, very important to assess the patient, assess the owner, and you have to pick up so many information and thorough examination. Then only you have to, and before that you forecast for each and everything. You have to forecast. So there we have success. See, even for atopy or any immunotherapy, you should say, if you give this, it will take this time, or this is the probable time we can expect to have a cure, or something like that. We cannot say in, that's why the problem comes. So if you are going to give an apoquil, they think after giving 10 tablets, everything will become all right. So you should say that it is the beginning, it is not the end. By 10 tablets, it's not going to get over. So the lifelong treatment, multimodal approach, all those things, this is like a lifestyle disease, like a diabetes, like a asthma. It is having a problem throughout life, so that has to be monitored, or it has to be adjusted with the production of antibodies for the particular allergens. Like that, we have to tell the owner properly, then only we can have a good result. That is what my experience.
Thank you, sir. Sir, next question is open to all of you. What are your guidelines for allergen testing, and what are your guidelines with your vast experience about choosing the correct prescription diet in atopic cases?
So, as I understand that you don't do a lot of allergy testing here, right? We started, okay. So I personally do a lot of skin testing, okay? If I am not able to do skin testing, then serology testing. Okay, so there are a couple companies in the US. So there are some companies that block the IgE against the CCD and some that do not. Okay, so I only submit to companies that do it. For example, IDEX. Okay, and because I don't know how familiar you are with this concept, but in the past we used to say that skin tests and serology tests don't correlate very well, right? And that could be for a variety of reasons. One is because of the source of the allergens is different, but one that we learn now could also be that many dogs, cats and horses, this is across species, have IgE against this cross-reactive carbohydrate determinants, which are basically conserved across a variety of things, from foods to insects to pollen and so on. And these IgE are clinically relevant, but they lead to a bunch of false positive responses on your serology test. So if you were to submit to a company that is not aware of it, is not blocking it, then you're going to get garbage results that you don't know how to interpret. So that's, so there are some companies in the US that I know for sure they don't have good quality control and they don't block those, and so I don't submit there. And then, I don't remember specifically the words I used, but before that, one thing that I encourage you, if you start doing serology tests, the catch is that you cannot look at the results of the test and assume that the higher the number, the more clinically relevant it is, because it doesn't work like this, right? So you need to correlate the results that you get on your serology test with the seasonality and the history of your patient, okay? Because you may have some things that have a high number, but they're not clinically relevant. So you need to have a knowledge of what pollinates at what time of the year and what the seasonality of your patient is. And that will help you to select what to put in your immunotherapy. You're shaking your head. So this is, there's a study that showed that when immunotherapy was prescribed by a dermatologist, it worked based on serology. It worked better than when it was prescribed by a practitioner based on serology. And the only difference was that the dermatologist was selecting the allergens looking at these parameters rather than looking at the total score of the serology. In terms of the diet, it's a difficult question because there is no easy answer. Okay, so each strategy has a limitation. So I did a lot of novel protein diets. I don't use so much hydrolyzed diets. In the US, I use a lot of analergic, and I would say probably it is the fastest way to get an answer whether food matters or not. And then more recently, we had a Purina diet, which I understand is not here. It's called Elemental, which is synthetic amino acids, and that seemed to work well until it was removed from the market. So I would say analergic.
So just to endorse, basically, my thesis work was on the allergen test back in 1987, so working with immunologists. So why we do the immunotherapy, because a lot of clients do ask now, because I have access to information, including sublingual. They keep reading everything, and including the latest packs, from the next Mune. So people have well aware of all the information, but I do tell them that, the purpose of immunotherapy, and so unless, they go for this, I would not do it. In my experience, most clients, our clients, so they want a quick fix. So I was just sharing with that, when we did the immunotherapy, so most clients did not turn up after a month. Despite calling that free transport, everything, they said, no, I want a quick fix. The doctor locally has treated that one. So secondly, testing, as you said, the allergens are so different from India, from Bangalore to Chennai to Bombay. So I need to have someone, local manufacturers, who can make the, based on the pollen mapping. He has to make a kit, it's very relevant to India. So I have many cases where the sample has been sent abroad for the big list of allergens, including food allergens. And that's really a waste of money. So I would never do that, so unless someone develop it locally. So for me, immunotherapy is not successful. Diet, I think I still agree with that, at the moment, analergenic something, as per the literature, I found it quite relevant at the moment.
To me, actually, it is quite different from Dr. Umesh. Actually, we have got well-identified allergens in Chennai. So we have done a study over a period of more than 10 years. We have done a study over this. So in that, we have identified top 10 allergens in Chennai.
So you can take the mic. Yeah.
So that works very well, and even we have got a very good response, because we have not gone through the pollen calendar, what is available in the this thing, Google or whatever it is. The pollen calendar given by the botanical research fellows, of course it is, we will be taking as a baseline. Then from that we will be selecting our own this thing. We will be identifying the area from which the dog is coming, and what are all the possible pollens in that area. We did some work on it. We have taken photographs of all the trees and pollen and other thing, and we made a PPT and given to all the dog owners who are coming, and we will be asking them to select which are all the plants or flowers what you come across. So from that we have selected, and we started giving intradermal injection and identifying the IgE which is going to have more this thing. From those allergens we will be giving immunotherapy. So in that case it was working very well. But we have to do for individual state because as doctor was telling, it will be quite different from Chennai to Bangalore or Bangalore to Mumbai, something like that. I think it is very easy to follow what humans are following. So that is they are based on this pollen map only, I think they are doing. Apart from that, they have also done the study. A lot of people have done the study, and they have got the bank like thing, what are all the pollens in this state, what is the pollen available in this state. From that we can have an idea, and we can have the creative diagnostic in Mumbai, they have the allergens. So from that only I started doing the work for intradermal testing. Later we started doing from our own, in Chennai we have got the persons, so they do the thing and they know what are all the pollens available in that area. So in that we have done some good immunotherapy. Along with that, recent paper says before starting immunotherapy we have to control the aggressive signs of the atopy. So once we have a considerable improvement in the clinical signs, then only if you start immunotherapy, you will be having a good result. And once you are going to have the result, the owners will be very much appreciative, and they will come over again and again. And it was, for me, it is quite successful. Actually, that is the, they have to get convinced first. You have to see the improvement in the animal, then only they will get convinced. That's what my experience. Thanks.
Any other questions which the panel can discuss?
Hello. So it is the autohemotherapy is useful in this dermatology or in skin disease? Autohemotherapy.
I don't have any experience, sir.
I mean, okay, we started for warts to everything. So we have avoid so much, okay, so we have to strongly believe the science, which I said in Bangalore. Oh, it's called autoimmunotherapy. Basically
they'll take the blood and inject
back into the serum or the blood, okay, so do you still believe that? Okay, so you think something would work?
Well, there are studies, I don't do it, but there are published study for horses that they did the auto serum, and apparently it worked well. I don't have, I'm not opposed to it, but I don't have direct experience. I think it's something that we need to maybe look into further. In the same way, in the States now, we're starting to do mesenchymal stem cell therapy. So I think the body has the ability to heal, but we need to become smart about it.
Any other questions?
Okay, so okay, using only salicylic acid as a topical. So is it a voting salicylic acid shampoo? So she did talk about salicylic acid. Probably I'll give it to her first. Okay, so using a salicylic acid topically. So I mean, like, what is the percentage? Okay, what you would recommend? Okay, so.
To the best of my knowledge, so many times they are in combination with sulfur salicylic acid, so they have keratolytic, keratoplastic activity. So when you have some seborrhea, we use it for that. So yes.
Okay, so one question that I have for the panel is, we promote cyclosporin, and I've been selling cyclosporin for the last about 20 years. No cyclosporin is used without therapeutic drug monitoring. how has been the experience, if at all there has been an experience of using cyclosporin along with therapeutic drug monitoring when you use in patients of atopic dermatitis? And if there is a possibility, can we do something like that?
There's actually a study that looked into that and did not support the need of monitoring nor a correlation between the levels and the clinical response. And I think that that's why people don't do it anymore. I think initially they thought that that was a way to monitor therapy or predict who was going to be a responder, and we learned that it wasn't.
Okay.
So
I think some of doctors do ask the question, what is the ideal trough concentration? Similar to phenobarbital, we check for epilepsy. So I don't know whether we have any recommended trough concentration. So there is one lab in Bangalore, they do measure the cyclosporin for the kidney transplant. So to my knowledge, I don't think actually said, we don't have any trough concentration, which is recommended to be ideal. Yeah.
So we're measuring circulating levels, which may not be reflective on the response in the skin. I think that might be a critical difference between atopic dermatitis and other diseases for which we do the systemic monitoring of levels.
I wanted to know, we've been recommending tacrolimus, and in human kidney transplant patients, they are checking TAC levels. Basically, tacrolimus toxicity, or because they're using it as an immunosuppression in the recipient. So, is there any work being done on animals, because we are using tacrolimus? It's being recommended.
Systemic tacrolimus.
Right. So, I mean, I've only used tacrolimus topically in my patients, and so that's not a concern. I think even the black box warning that we had in the U.S. was about systemic use, and they came from like studies and animal models in the lab where they were given large doses systemically. So I'm not aware of any toxicity that has occurred in small animal after topical application. So I guess there's a possibility if the animal is really small and you have extensive ulcerated areas, and so you have a large systemic absorption, but I typically don't worry about it.
Just to add to that, I think, I invented a disease called Kiskin syndrome. So I think those cases we did use the tacrolimus. What I want to also tell you that there is a preparation containing tacrolimus spray. So I did ask a lot of dermatologists, like, do you have a tacrolimus spray in your market? Only the ointment. So because I'm still asking for a date on using a spray, because it's quite really not ideal to use a spray versus the ointment. So I would avoid the spray, whatever may be the brand.
So we don't use any oral parenteral tacrolimus, so there is no question of toxicity in that. So topically only we are using like Itchmune tea and other things, so it is quite, we have a very good result. And focal lesions only we will be going for it, so there won't be any issue in that.
Okay, there's one question from Dr. Aditi Chitnis, please. Mike. Volume, ma'am. Just pull it up.
Yeah. Yeah, definitely it will happen, but not necessarily it should be a Kiskin. Even any combination, because the name is quite attractive, everyone is telling that. It is not like that. Actually, we need not tell any brand. Whatever content, the same content of Kiskin, if it is going to be there in other brand, it is also a syndrome. So it is most commonly used because of the favorite name. Many people, I think, they are more attracted to that ointment, lotion.
as a parameter to maybe establish it? And is azole, maybe ketoconazole, ever used in the treatment of this?
Two-part. Okay, I think first question is on the skin. The reason I brought it because I saw a lot.
His dog for 6 months.
You see primarily in the pugs. In the pug, if you see majority of all pugs, okay, with the milium, okay, what I classical there is the thinning of skin. Then okay, so UCCR ratio, we use it as a screening test, not really confirmative. I think there was a recent paper also it can be used even for hypoadenocorticotropism also as a screening test. But we always try to do the LDST and all. But many times it's always like a thin line between iatrogenic versus okay, the spontaneous. So many times when I have a history that dog has received the steroid, I definitely have plenty of cases where we tapered and we are brought back to normal. I have a good number of cases which are iatrogenic, okay, basically in the atopic dogs. Spontaneous we do see, but ketoconazole, because we don't get the Vatoril or the equivalent brands, okay, we use that salicylene, ketoconazole, and okay, but not promising anything. But I don't find any great improvement okay, with the ketoconazole alone. But there's only last resort I have at the moment, very few can able to get the Vatoril from abroad.
Oh, we don't have trilostane. No. Okay. No.
Thank you so much. I think the last slide was of Dr. Umesh. I think one last question. Yeah, one
Okay,
last
I'm
question.
sorry to take up so much time. Right there. I forgot my question. Okay, sorry. Sorry. In the face of a lot of environmental allergies, especially for a lot of breeds that are not meant to be in this country, do you have any particular grooming practices you would recommend to your clients? Say longer coats or double coated breeds which are a little harder to maintain maybe?
With specifically to get rid of the allergens?
Yes, especially if they have environmental allergies. If we do enough tests to check for pollen allergy and stuff like that.
I mean, okay, so I think as you said, okay, vacuum cleaning, you know, dust mite, okay, all the stuff, okay, room cleaners, okay, room purifiers.
No. For the dog itself.
And for the dog, obviously the people. And shampooing, obviously any shampoo, even the water also can really get rid of allergens from the skin. So do you have anything to add okay, to that one?
I discourage.
Thank you so much.
I discourage clipping. So you want to have, if they have some protection from the coat, leave it like that. So frequent bathing with appropriate product, but no clipping. That's my.
Thank you so much. The question and answer session in the Parliament of India is attended by less than 20 people. So I think we had quite a number of questions, and I would like to thank each and every one for taking time out to come and make this conference and summit a grand success. So we can give a pat on the back that it was great, and thanks to all of you. I would request my colleague Mahendra to hand over souvenir to all the speakers as our gratitude for their time doing today's summit. Hey, ask. Dr. Nagarajan. Dr. Mesh. Thank you so much. I think Dr. Jairam Ramani has something to say. Okay, I will play the video. So let us get the chairs down, please, Manish. So before I hand over the mic to Dr. Jairam Ramani, I would like to propose the vote of thanks. This meeting would not have been possible without all of you coming, and many of you are here till since probably 12 o'clock, and thank you so much and making this program a grand success. My entire Mumbai team, my colleagues in the head office, all have contributed to the success of this summit. We'll be back next year with one more round. I'm sure about it. Thank you so much. The dinner is laid out, so the bar closes at around 10:30, I guess. So I would request all of you to have a nice dinner and a great weekend tomorrow, and good night. And Doctor, you can play that video. Volume. Audible, it's not audible. Volume आता है उसमें. एकदम घटिया है. The AB guy is horrible. He doesn't know. Silent. It's been a silent video, but again we will get a chance. Just a minute. I'm so sorry for this. अभी इसमें नहीं आ रहा है. अवस्था. No, not mine. It is running from there. I don't have any control. Thank you so much, sir.
Very well organized.
Thank you so much, sir. There have been a lot of mistakes, but again,
One most important is your all involvement from the very bottom of the heart we were seeing from every.
thank you so much, sir.
Good efforts and very good progress.
Thank you so much, sir. Thank you.
नमस्कार पशुवैद्यक मित्रांनो, मी धनंजय बापू प्रेसिडेंट आणि तुम्हा सगळ्यांना मी आपल्या ऑक्टोबरच्या वर्ल्ड काँग्रेसला एशियन काँग्रेसला बोलवत आहे. तुम्ही सगळ्यांनी यायचं आहे. हा एक फार मोठा इव्हेंट आहे आणि तुमच्या सगळ्यांच्या सोबत आपल्याला तो फार मोठ्या प्रमाणात मस्तपणे एन्जॉय करायचा आहे आणि नॉलेज पण शेअर करायचं आहे. धन्यवाद. जय हिंद, जय महाराष्ट्र. जय हिंद, जय महाराष्ट्र.
India, and the venue is the Western at Mumbai. We have organized an interesting congress with 6 themes covering a variety of subjects from canine, feline and exotic. World-renowned experts are going to be attending this event, and please take advantage of learning from their knowledge. We have added an Asian flavor by including leaders from Asia and the Indian subcontinent. The venue is Mumbai, India's financial capital. Please take the opportunity
financial capital